Thank you, Rahul. Ladies and gentlemen, welcome to the grand finale of the Virtual Annual Congress 2020 of Kolkata Academy of Ophthalmology. COVID-19 has brought in a paradigm shift in the way we practice, not just ophthalmology, but all other disciplines of medicine. You can make out from my attire, I'm wearing a mask, I'm still in the clinic, I'm wearing a microphone, I have my so-called N100 mask behind me. So things are no longer the same. And we are in Kolkata Academy very proud to say that we are encouraging a scientific temper whereby we can discuss ways forward to deal with the new situation. The present situation needs a proper, logical, information-based approach to deal with our everyday problems. So we have an array of very learned people with us today who will talk about the new approaches related to COVID. At the same time, they'll debate, they'll ask questions regarding the problems we have faced in our glaucoma management in the past as well. There is a miasma of fear amongst us as to how to approach our patients because, as you all know, ophthalmologists are at a very high risk. So we need to, again, discuss and decide on certain SOPs and protocols. Shakespeare mentioned that virtue is bold and goodness is never fearful. So we have to have a virtuous, a good, proper, evidence-based protocol so that we can approach our day-to-day problems with equanimity and composure. We plan to delve into that matter this evening. And to guide you through this program, we have our moderators who need no introduction. We have a very able Dr. Chandrima Paul, who's our chairperson. We have a young and dashing Shuraj Chakraborty. We have an experienced Dr. Shumit Chakraborty, who will lead you through today's program. Ladies and gentlemen, let's fasten our seatbelt while we take you on a very interesting and informative journey. Thank you all and welcome.
Thank you, Dr. Rajesh, very much. That was a wonderful start to today's program. And I really don't need to introduce anybody this evening because they're all stars in their own fields, but it's customary to do so. So I'm going to share my screen to introduce all the guests. So can you see my screen?
Yes, we can see your screen.
So the keynote speaker this evening is none other than Dr. Padma Shri, Dr. T.P. Lahane. Unfortunately, he's stuck up in a government meeting with the Maharashtra CM, so he might be a little late joining us. He was awarded the Padma Shri in 2008, Dean of Grant Medical College and Sir J.J. Group of Hospitals, pioneered advanced phacoemulsification technology in government sector of Maharashtra, appointed as Joint Director in 2007. At present, he is the Director Medical Education and Research, Maharashtra. Very warm welcome to you, sir. Next, we move on to our experts who are going to give their viewpoints on various topics. To start with, we have the youngest speaker of this evening, who is a next generation ophthalmologist, and we are really proud of him, the good work that he's doing, Dr. Vedant Shah, consultant at Sri Netra Eye Foundation, Kolkata, presently the chairman of the West Bengal State Chapter of the YOSI, and an executive member in the National Committee of the Young Ophthalmologist Society of India. Special interests include OCT angiography, diabetic retinopathy, and retinopathy of prematurity. He would be speaking on OCT angiography in glaucoma. Very warm welcome to you, Dr. Vedant. The next speaker is also none other than very famous in his field, Dr. John Davis Akara, consultant ophthalmologist, cataract and glaucoma services, Little Flower Hospital, Angamali, Western Eye Hospital, Cochin, fellowship in glaucoma from the Aravind Eye Hospital, keenly interested in programming and making apps related to ophthalmology. He would be speaking on technology in glaucoma. Very warm welcome to you, Dr. John. Dr. Ragini Parikh, a good friend of mine, the head of the Department of Ophthalmology, JJ Hospital and Grant Medical College, a renowned and versatile surgeon who caters to patients from interiors of Maharashtra as well, was elected as one of India's top 100 women achievers in 2006, would be speaking on concomitant cataract and glaucoma, interesting issues. A very warm welcome to you, Dr. Ragini. Dr. Chitra Ramamurthy, a good friend of mine, and we go a long way back. So medical director of the Eye Foundation at Coimbatore, Tirupur, Uti, and Metupalayam, that's a tongue twister, and trained at the premier eye centers around the world in Germany, Netherlands, Switzerland, Australia, Hong Kong, and Singapore, recipient of the Shiva Prasad Hardia Award for Refractive Surgery at the AIOC 2009 Jaipur, has contributed to different textbooks in refractive surgery, is presently the chairperson of the Academic and Research Committee of the AIOS, and would be speaking on early bleb challenges management. A very warm welcome to you, Dr. Chitra. Dr. Vanita Pathak Ray, consultant, Center for Sight and adjunct professor at the University of Hyderabad, India, formerly consultant, LV Prasad Eye Institute, Hyderabad, fellowship in glaucoma from the University of Toronto, Canada, is a fellow of the Royal College of Surgeons, Edinburgh and London, and will be speaking on primary tubes in secondary glaucoma. Vinita and I actually go back many, many moons to the time that she lived in Cardiff. A very warm welcome to you, Dr. Vanita. We move on to Dr. Vibhuti Prasanna Sinha, a very well-known personality in the east of India and the country, professor and HOD, RIO, Patna, established and running the glaucoma clinic at RIO since 2003, a revered teacher with multiple peer-reviewed publications, and has also authored chapters in books, will be speaking on post-traumatic glaucoma. A very warm welcome to you, sir. Dr. Murali Ariga, Senior Consultant and Glaucoma Specialist, MNI Hospitals Private Limited, Observer Fellowships in glaucoma at the Schnell Eye Hospital, CMC Vellore, and New York Eye and Ear Infirmary, New York, USA, has more than 20 publications in ophthalmic journals, teaching CD and automated perimetry and glaucoma, chapters in textbooks on glaucoma, and chapters in the AIOS Ready Reckoner 2010. He was awarded the Best Scientific Presentation Award at the Glaucoma Society of India meeting in Chandigarh in 2008. He would be speaking on Micropulse TSCPC, a game changer in glaucoma management. Dr. Murali and I have literally grown up together in the GSI. A very warm welcome to you, Dr. Murali. Dr. B.N.R. Subuddhi, Professor of Ophthalmology at NRI Medical College, Visakhapatnam, Andhra Pradesh, ex-head of the Department of Ophthalmology, MKCG Medical College, Behrampur, multiple peer-reviewed publications, has graced numerous important posts at various national and state-level ophthalmology associations, awarded Professor B. Rajguru Oration by OSOS in 2016, and the IIRSI Gold Medal in 2018, a very revered teacher in the eastern part of the country. A very warm welcome to you, sir. Dr. J.K.S. Parihar is a senior consultant ophthalmologist, Center for Sight, was additional director general, Armed Forces Medical College, Medical Research, Health and Training, ex-professor of ophthalmology at the Command Hospital, Kolkata, and AFMC Pune, has published 102 research publications in national and international journals and presented 705 research papers, has authored 5 books and many chapters in ophthalmology texts, is a peer review and multiple international journals. A very warm welcome to you, sir, and we go back a very long time to the time that he was at Kolkata. Dr. Mona Khurana, currently working as senior consultant in the glaucoma department of Shankara Nethralaya, from where she also did her fellowship. Interests include imaging in glaucoma and patient adherence to medications, teaching being one of her passions. She has been teaching research methodology on outline platforms for many years. A very warm welcome to you, Dr. Mona. Dr. Dipanjan Pal, Senior Cataract and Glaucoma Consultant, Disha Eye Hospitals, Fellowship from Aravind Eye Hospital, Madurai, is an active member of the Glaucoma Society of India, member of the American Academy of Ophthalmology. A very warm welcome to you, Dr. Dipanjan. Dr. Shagorika Patyal, working in the field of glaucoma for more than 25 years, presently is consultant at the Center for Sight, Delhi, alumni of Medical College, Kolkata, has served armed forces for more than 30 years, retired as Professor of Ophthalmology, AFMC. A very warm welcome to you, Dr. Shagorika. Next, we have Dr. Devdas Mukherjee, is a senior consultant at the BKG Malda Eye Hospital, West Bengal, is a fellow of the Royal College of Surgeons, Edinburgh. Next, we have Dr. Ruchi Goel, Professor Maulana Azad Medical College, New Delhi, author of more than 90 articles and 16 book chapters, co-authors of popular ophthalmology books, has been Joint Treasurer, Member Scientific Committee and Member ARC of the AIOS, awarded Gold Medal by the IIRSI, and Dr. B.N. Khanna Oration by the DOS. A very warm welcome to you, Dr. Ruchi. Dr. Sirish Nilivigi has worked in the field of anterior segment of the eye and especially in the subspecialties of cataract and glaucoma for a period of 14 years, among the first in the country to do surgeries like selective laser trabeculoplasty, carbon dioxide assisted trabeculotomy and deep sclerostomy. Has several publications as well as chapters in ophthalmology textbooks, has won several best paper awards in the state and national conferences for various presentations. A very warm welcome to you, Dr. Shirish. Dr. Vineet Ratra, Consultant Shankar Nethralaya, special interests include glaucoma and cataract, has multiple peer-reviewed publications. A very warm welcome to you, Dr. Vineet. Dr. Medha Prabhu Desai is the Director of Insight Vision Foundation, Honorary Assistant Professor, Bharati Vidyapith and Medical College, Pune. A very warm welcome to you, Dr. Medha. Dr. R. Sharmila, Senior Consultant, Glaucoma Services, Aravind Eye Hospital, Madurai, completed her fellowship in glaucoma from Aravind Eye Care System in 2004, done short observership in glaucoma services of Wills Eye Hospital, Philadelphia, Wilmer Eye Institute, Baltimore, Duke University, Durham, and also at Moorfields Eye Hospital, London. Has multiple peer-reviewed publications. A very warm welcome to you, Dr. Sharmila. Dr. Sujata Mohan, Associate Medical Director of the Rajan Eye Care Hospital and a specialist in anterior segment surgeries, is the Director of Rotary Rajan Eye Bank. A very warm welcome to you, Dr. Sujata. Dr. Chinchira Sangma, Consultant at Shankardev Nethralaya, Guwahati, takes special interest in the subspecialty of glaucoma, comes from my part of the country. A very warm welcome to you, Dr. Chinchira. Dr. Shalini Mohan, Associate Professor at GSVM Medical College, Kanpur, trained at the RP Center, New Delhi, and has multiple peer-reviewed publications. A very warm welcome to you, Dr. Shalini. Dr. Rashmi Krishnamurthy, Consultant at the LBPI Hyderabad, pursued long-term fellowship in glaucoma from the LBPI Hyderabad, is well-trained in managing both adult and childhood glaucomas, has a keen interest in research and academics, and has published papers and presented at various conferences. A very warm welcome to you, Dr. Rashmi. Dr. Aditya Agarwal is a renowned ophthalmologist from Indore. His area of expertise includes cataract surgery, glaucoma, and refractive surgery. I remember him very well at the Indore Glaucoma Society of India conference, which he organized very well. A very warm welcome to you, Dr. Aditya. With that, we come to end of the introduction, and I would stop sharing my screen, and I would request Dr. Vedang Shah to start on with his presentation. You can go ahead with sharing your screen, Dr. Vedang.
So am I audible and my slides visible, ma'am?
Yes, yes, yes. Go ahead.
Yeah, just waiting for it to share the screen, the slide view. Okay. So thank you so much, Dr. Chandrima Paul, ma'am, and Kolkata Academy of Ophthalmology for giving me this opportunity. It is an extreme honor, especially to speak in front of my seniors, my teachers. Today, I will be discussing about the role of OCT angiography in glaucoma. When it comes to glaucoma, we have a lot of options, starting from perimetry, swab, OCT, RNFL, fundus photography, octopus, and the perimetry. But then always, whenever there's a new investigation that comes in, it gives us a delight, and especially if it is it causes less burden to the patients, and definitely helps us in diagnosing the glaucoma earlier and monitoring it better. In such a way, the OCT angiography has definitely been a boon for us, considering that the blood flow in the ONH was tried to be monitored by a number of ways, like the Doppler OCT, the laser spectrography, and there is also the FFA. But then what was missing was the reliability, because every time the measurement was done, it was unreliable. There was a variability in the measurement. So the OCT angiography in this way, I think probably helps us a lot. Number one, it is non-invasive. There's a repeatability, so we can assess the treatment response. There is early detection of the vascular pathology. It can be done at each visit. It takes hardly a few seconds to do the OCT angiography. We can monitor the disease progression using the analysis, and also it provides us an insight into the pathogenesis of the retinal glaucomatous and the neurological diseases. So just to give a brief of how the OCTA works, it works on the principle of the diffractive particle movement detection. So the blood cells, the sequential OCT B scans are taken, and the differences between the B scans generate a movement-related contrast, and that provides us with the OCT angiography B scans. So it also has the real-time tracking image. So for patients who are uncooperative, who are elderly, who are unable to monitor the screen or view at the focus point, so this provides us the real-time fast-track imaging, thereby it eliminates the motion artifacts. At the same time, there is the OMAG algorithm, which uses both the amplitude and the phase difference, and thereby generating a good OCT angiography image. So before we dive deep into the OCT angiography of glaucoma, it's important to understand the slabs that we are looking at. So the superficial vascular complex, basically it comprises of the nerve fiber layer, vascular plexus, and the superficial vascular plexus. The deep vascular plexus comprises of the capillary plexus and the deep capillary plexus. And then we have the other slabs, which are more important for the retina angiography than for the glaucoma angiography. This is how the vascular complexes look on the OCT angiography. Where to look for glaucoma in OCT angiography? One is the optic nerve head, second is the peripapillary area, and the third is the macula. So the peripapillary area and the macula are the two most important regions. In the peripapillary area, it is the nerve fiber layer which is affected the most. And in the macula, it is the nerve fiber layer and the ganglion cell layer where we have to look for glaucoma. So I use basically the no financial interest, but I use the Zeiss Cirrus 5000, and this is the angioplex images from the Zeiss machine. I use the 4.5 into 4.5 scan of the ONH, and this gives me a complex and a composite image of the B scan of the ONH. Second, it provides me a structural image. Next, it provides a vascular tracing image. And finally, the ganglion cell image, which also provides the perfusion and the flux index. So it is sometimes difficult to identify and follow the blood vessels, especially because the neuronal bands are quite thick at the optic nerve head. So that is why the peripapillary imaging is equally important to identify glaucoma at the early stage. What are the metrics that we use to calculate the index, especially in patients with glaucoma? One is the quantification of the radial peripapillary capillaries, and the two is the metrics that we use for the optic nerve head. So that is the capillary perfusion, the flux index, and the vascular density. The capillary perfusion is defined as a percentage of area that contains the perfused vasculature, and the flux index is defined as a capillary perfusion weighted by the brightness of the flow signal. So as we go from 0 to 1, I mean, as we are nearer to 1, it is towards the normal, and as we come down lower towards 0, it indicates that the glaucoma is advancing. So this is how the screen looks when we have taken an optic nerve head angiography 4.5 into 4.5 scan. What we have is the angioplex with the perfusion map and the matrix. Then we have the structural on-face image. We have the B scan with the blood velocity. So we can see the blood, we can see the blood overlay, blood flow overlay here. And we also have the RNFL thickness map. So it gives us a composite image of everything in one go. We need not look further to diagnose glaucoma. Individually, this is the structural image, and this is the vascular or the vessel tracing. So especially if it's an advanced glaucoma, it helps us to identify the vessel tracing very easily using the algorithm. Just to show how the glaucoma changes from normal to advanced, and we can see how there's a change in the vascular density from normal to the advanced, how there is a change in the perfusion index, and how the flux index keeps reducing. And it is similarly corroborated by the change in the RNFL thickness. So we can see how beautifully it simulates the RNFL thickness and thereby picking up glaucoma very early in the pre-perimetric stage. In one of their studies by Liu et al., they clearly showed the importance of locating the peripapillary ONH nerve fiber bundles, and we can see that how the defect here in the RNFL corresponds to the visual field here. Similarly, the peripapillary flow index and the vascular density, especially the vascular density, how important it is to identify the glaucoma. In another study published in the Asia Pacific Journal of Ophthalmology, it was clearly seen how the advancement in glaucoma corresponds to the optic nerve head changes and also in the visual field. So we can see the increase in the glaucoma, increase in the cupping, the visual field corresponds exactly to the change seen in the vascular density network, which decreases in the advanced glaucoma. Coming to the macular area, so as we discussed in the macular area, we have to look at the nerve fiber layer as well as the ganglion cells. So it is important to note that a macular angioplex scan of 6 into 6 mm is important. So there are multiple scans available at the macula, say from 3 mm into 3, 6 into 6, and then 8 into 8. But the 6 into 6 mm provides us the ideal one to look for the glaucoma. Almost 30% of the ganglion cells lie at the macula, and these cells could be one of the earlier ones which are damaged in the glaucoma. So when we do a macular imaging or the angiography of the macula at the 6 into 6 lab, we can see how the decrease here in the capillary density corresponds to the decrease in the ganglion cell layer here, and equally corresponds to the visual field defect which is seen in the perimetry. See how the OCT angiography simulates the visual field. So David Huang et al. In their paper, they have divided the optic nerve head into 8 divisions, and here we can see that the defect in the quadrant 6 corresponds very clearly to the defect here in the OCT based simulated visual field total deviation. And this is also similar to the one which they have been seen on the HFA. So one thing that I would like to mention here is with the perimetry, there is a floor effect. But with the OCTA based simulation of the visual field, there is a less floor effect. So what do I mean by the floor effect? So as the glaucoma advances, the nerve fiber layer, it keeps shrinking. There's an atrophy. So which corresponds to the mean deviation which is seen in the perimetry. But after advancement, say from moderate to advanced glaucoma, the nerve fiber layer, it reaches a floor effect. And finally, and that is why we cannot see much difference in the mean deviation, and the patient keeps advancing in the glaucomatous stage. But with this, because the OCTA is dependent on the capillary density and or the vascular density, even in advanced glaucoma, we are able to continuously monitor and identify the changes. So that is why there is less floor effect with the OCTA measurements. How does it simulate the OCT-RNFL? So it's been clearly seen here, with especially in the moderate to advanced glaucoma, the change in the vascular plexus density and the change in the ganglion cell layer, how it corresponds to the OCT-RNFL, and similarly corroborates with the findings seen in the visual field. So the point mentioned here is the OCTA can detect early perimetric glaucoma better than structural OCT. And why do I say so? Because the OCT RNFL detects only dead ganglion cells, but the OCTA detects dysfunctional ganglion cells as well. So wherever there is a dysfunctional ganglion cell or wherever there is a less vascular permeability or a density, it can identify. So that way we are able to identify the glaucomatous condition early. OCTA is definitely helpful in all the subtypes, be it open angle glaucoma, be it pseudo exfoliation glaucoma where there is a reduction in the capillary density, or in especially there is a paper which has been published and it shows that after initiating treatment in ocular hypertension and normal tension glaucoma, how the vascular density has increased with usage of the topical beta blockers. Yet there are still some unanswered questions, and I think probably we'll have to wait to get the answers for them. Does the loss of circulation occur gradually or is it episodic? Or there are some patients where there is a loss of capillary vascular density first, followed by the nerve fiber atrophy, which may be in some cases, we don't know. And does the ocular systemic and the physiologic factor change or cause some deviation in the microvascular perfusion? So I leave you with these questions and I hope to answer them in the next meeting. Thank you so much, ma'am.
Thank you very much, Dr. Vedang. That was indeed a very informative and wonderful talk. And we shall take on some questions during the discussion period. As of now, we'll move on to Dr. John with his talk. Wonderful talk, Vedang.
Thank you, ma'am.
Thank you, ma'am. So I'll be talking about newer technology in glaucoma. Let's get right on to it. I have no financial interest in this presentation. So the diagnosis of glaucoma, it starts with IOP, disc and the retinal nerve fiber layer and GCC.
Could you share your screen, Dr. John?
I think, okay, I'll just share it again. Okay. Is it visible now?
Yeah, perfect.
Okay. Okay. So I have no financial interest in this presentation. The diagnosis of glaucoma, it starts with intraocular pressure, disc and retinal nerve fiber layer, gonioscopy and perimetry. So these are the cornerstones of glaucoma diagnosis for several years. And now let us look at what changes we have in all these things. In glaucoma diagnosis of using intraocular pressure, we have a lot of newer tonometers. If you look at all these pictures, we'll see that we have the ocular response analyzer, which uses the bidirectional air puff to get the corneal hysteresis. Then there is the Corvus ST, which uses Scheimpflug imaging to get a better value of the intraocular pressure. Then there is the Pascal, which is dynamic contour tonometry, which matches the contour to get a more accurate intraocular pressure. Then there is the iCare, which is very convenient to use, which uses a ballistic probe and doesn't require any local anesthetic. But even newer than that, we have the contact lens IOP monitoring with the Sensimed trigger fish, which you wear as a contact lens, and it uses changes in the corneal curvature, corneal stretching to measure continuous intraocular pressure. Then there is another implant called the iMate, which is implanted into the anterior chamber, and this also measures the intraocular pressure continuously. When you look at gonioscopy, there is the iCam, which is actually a fundus camera, but that can also be used like this to take photographs of the angle. Red cam, which is also the fundus camera, can be used in a similar way to take photographs of the angle. Beautiful photographs and even videos of the angle can be taken in this way. But there is also a specific camera made for imaging the angle called the goniopen, which is from the Singapore National Eye Center. It uses similar method to directly take gonioscopic images and videos. Then there is the GS1, which is using a 360-degree camera, which can actually take a complete 360-degree image of the angles. And this is using a 16 mirror gonio lens like this. And this machine will help in evaluating the angle at multiple focal points so that you can adjust the focus later also. When we look at the anterior segment OCT, we have now the dynamic anterior segment OCT, which can look at the anterior segment in video. We can see movements in the anterior segment. We can see the iris contraction. We can see the angle opening up. And the swept source OCT, which we have in retina, is now available for the anterior segment as well. Then in ultrasound biomicroscopy, there is 3D ultrasound biomicroscopy, which allows 3D images similar to the OCT, anterior segment OCT images which we saw just now. And this can be used for iridocorneal angle assessment. It can be used for assessment of the ciliary body in 3D. So these are all out there right now. This is published in March 2020. And then, of course, Dr. Vedang spoke about the OCT angiography. There is a lot of use for OCT angiography. Then we have the stereo photography, which was there, the swept source OCT, the Doppler OCT, the adaptive optics technology, which is added to all these OCTs now, the polarization sensitive and the visible light OCT as well. And in addition to that, we have all these coming up, multispectral imaging and MRI for the eye, magnetization transfer imaging and all these things. Then there is retinal oximetry, which looks at the oxygen saturation in the blood vessels of the retina. And artificial intelligence, I'll come to this later. All these modalities can be tied together using artificial intelligence to get useful information. So I'll get to this in a later slide. So we have many changes in the retinal OCT also. We have better resolution and we can look at the lamina cribrosa in detail because that is also important in glaucoma. And there is something called DARK, which is detection of apoptosing retinal cells, which uses a fluorescent marker called annexin 776. And this will be able to find out which of the retinal cells are undergoing apoptosis. So you can look for changes in the retina, and in glaucoma you will see the ganglion cells are having apoptosis. In perimetry, we have the laptop perimetry, which is you just can do perimetry on a laptop screen. So that is not very accurate, but it is very convenient. Then there is a tablet perimetry, that is you can do the perimetry on an iPad or an Android tablet. And then we move on to the innovative aspects of this perimetry. That is, you have an eye tracker which can be clipped on to the tablet, and this will have a camera which continuously monitors the gaze of the eye. And if you look at this is very portable and inexpensive compared to the regular perimetry. Now that we are in the fourth industrial revolution, it is obvious that we will have all these things, that is artificial intelligence, 3D printing, virtual reality, nanotechnology and genetics in our everyday lives, including in ophthalmology. So virtual reality is now being used for perimetry. So this is a prototype of a device which we worked on while I was in Arvind Pondicherry, and now it is available as a commercial device. And we were able to take perimetry using just this virtual reality headset, and the prototype was very inexpensive, and you just need an Android or iPhone inside, communicating by Bluetooth to a Bluetooth clicker, and the screen on the device displays the image. And this headset is less than 1,000 rupees, and you insert a phone inside. So that is also possible for virtual reality perimetry. This is one of the further prototypes, and this is the latest device. And the output comes up on a tablet connected wirelessly, and we are getting a pretty good perimetry. Then there is the problem of the subjectivity of perimetry. The subjectivity of perimetry is that the patient has to click to acknowledge that they have seen the stimulus. So to avoid that, we have the brain computer interface. That is, it is an EEG. It is a multifocal VEP, which will look for the stimulus received in the cortex, the occipital cortex, and it will do a perimetry without the patient having to click the stimulus.
Dilate with atropine once.
Then we have artificial intelligence. So artificial intelligence is already there in our regular usage. So when we look at OCT, the automatic demarcation of the disc and the automatic demarcation is using artificial intelligence. All these things use artificial intelligence.
See, from the visual point of view, this is
someone's talking. Could everybody mute their?
Pushes everything behind.
Like this?
This one seeing curve is pushed behind. So if you're looking to put one to one with minus one is the 1.5.
Dr. Vineet, are you talking there?
Spherical
Just put your microphone in your mode.
Give it time, is it? Too early. Tell her it's too early. If it
can you mute the person?
Can you mute?
Change the IOL or the LASIK.
Okay, so artificial intelligence is already there in our regular OCT.
I mean, I would definitely
the Sensimet triggerfish,
stand on a plus.
The Sensimet triggerfish, which is the contact lens IOP monitoring, which we saw.
I would definitely want to err on a minus than on a plus because I can treat it.
Can you mute him?
Plus LASIK.
Mr. Rahul, are you there?
Huh?
Mr. Rahul?
Mr. Rahul, are you there?
So she will have good reading.
I'll talk to him.
Just talk to him.
Yeah.
We need urgent.
Yeah.
Okay.
Plus 4 you put or plus 3?
I'll just wait for a bit.
Yeah. I think, John, you need to wait because unless
Sure.
the other person
Plus
is muted, you'll face problem.
Okay. Tell her she can read closer since you wanted better vision. Anyway, this will fluctuate a little. It's too early. And if we're having difficulty, we'll see. Just tell her that we will wait for it to heal.
This is very unfortunate.
Yeah, that has been muted. Yeah.
Okay.
John, I think you can continue, please.
Yes.
Yeah.
So let's continue. So I just mentioned about the brain-computer interface, which will make perimetry objective. The patient does not have to click to acknowledge the stimulus. The electrodes automatically detect when the patient has seen the stimulus. So it removes the subjectivity out of perimetry, and that is already available, and it's still in research, but it's available. And let's look at the artificial intelligence. I mentioned about the OCTs already doing segmentation of the optic disc margin and the cup margin using artificial intelligence. It's also useful for anterior segment OCT. And the Sensimet triggerfish contact lens, which I had mentioned, the data it gives is not direct IOP. It gives corneal changes, and that can be converted into intraocular pressure measurements by using artificial intelligence. So machine learning and artificial intelligence are used in all of these things, though we do not know about it. But it goes further. So this is just the graph of what the corneal measurements come out and converted into the intraocular pressure of the Sensimet triggerfish contact lens IOP measurements. And this is how the disc and cup are marked. So in addition to that, there is a lot of things in glaucoma specifically for artificial intelligence compared to diabetic retinopathy where we just identify the grade. Here we have visual fields where we have pre-perimetric detection of visual fields from perimetry. We don't need to do some other test to do pre-perimetric detection because AI can detect changes which we cannot detect as glaucoma specialists. And it can differentiate glaucoma visual fields. It can analyze visual field defects specifically. It can also analyze frequency doubling perimetry reports, and it can detect slow progression. So when we are not sure if there's a progression in slow progressors, this is able to pick up that slow progression without multiple tests. And this is particularly interesting. This particular group, they used 32,443 visual fields to train an artificial intelligence system, and it is able to predict the future visual fields of a patient. So they were able to get the input visual fields of a new patient and the IOP measurements and other parameters like age, and using that software they were able to predict that this is what is going to be the visual fields. So this line is what the predicted visual fields of this person were, and this is what the actual visual fields of the person were at 1 year, 3 years, uh, 1 year, 2.7, 3.6 and 4.5 years. So 4.5 years, up to 4.5 years, they were able to predict the visual fields. And this is another patient, the actual visual fields and the predicted visual fields by the AI system. And with this, you are able to target intraocular pressures for various patients. So we know that in glaucoma, it's not the same for all. We change our treatment depending on the person's life expectancy and so many other parameters. So we can target different intraocular pressure measurements and look at the change in visual fields at different ages. So, and the patient becomes, say, 60 years, it's going to be like this. If the patient becomes 80 years, it's going to be like this. If the patient is becoming 100 years, it's going to be like this. All this is possible. And we have this available right now in Orbis CyberSight. We have some AI capabilities for free. You can upload an image in this consult.cybersight.org, and they will evaluate your images with an AI for free. That is diabetic retinopathy and glaucoma. And 3D printing is another big thing. So we might have heard already about slit lamp adapters and smartphone fundus camera and surgical instruments, spectacles, eye drop helpers, and all these things which are used in ophthalmology. So glass dropper is a different model of eye dropper which we did in Arvind Pondicherry, and this particular model was eye drop helper was made in Arvind Madurai. And this is all done in-house. We just decided that we should make something useful and made the 3D printed model by designing the device in a software. We made a 3D model, got it printed, and this is what it looked like. We have also glaucoma buddy, and we have an implant. So this is from Mexico. Researchers in Mexico, they designed a 3D printed titanium implant which can be implanted for glaucoma as a glaucoma drainage device. And this is possible. That is titanium metal implant of very small sizes are possible with some of the newer 3D printers like Nanoscribe. Another device which is a nanofiber generating device. Okay, I don't have the picture of that. And they can generate nanofibers, and that can be inserted into the retina to slow down ganglion cell degeneration. This is into just animal research, but this one is Finnish animal research. That is another glaucoma drainage plant which uses a different mechanism with the dual drainage. So uses a dual drainage, and it uses a picoliter pump to adjust the intraocular pressure. Then there are apps for medication adherence. Then there is eye drop helper. It helps you to put the eye drops onto the eye safely. And then there are reminder bottle caps. So you can just put the eye drop into a bottle like this, and you can set the time, and it will give you an alarm when the eye drops has to be put. Of course, it is cheaper to use a free app, but this is also available. Then there is a device from Inovia. So this is a device which will spray a tiny accurate amount of the eye drop into the eye using a piezoelectric method that is similar to inkjet printing, and the patient just holds this in front of the eye. This targets the eye, it targets the eye and shoots the correct amount of medication onto the eye, and the patient doesn't even feel it. It hits the eye without the patient feeling it. And there is also a nano dropper, which is a redesigned eyedropper which reduces the drop wastage. It makes the drops small so that we don't waste the eye drops on the eye. And there are so many devices for in the routes of medication. So we have the bimetapros SR and the travoprost intracanalicular depot, which will be very useful for glaucoma patients because they need continuous medication for a long duration. And there is also this ring which is for bimetapros, and it's a polymer matrix insert which can be put into the fornix. This also is a long duration of medication. There are so many newer surgeries. I'm not going to go into that, but there are newer and newer surgeries coming up. You see so many new plans, minimally invasive glaucoma surgeries. So there's a Zen implant, there's the expression, then there's the eye stent, and so many things. And eyeglasses may one day treat glaucoma was a news I saw. And Dr. Ike Ahmed from Canada, he has been working with a group to develop glasses which electrically stimulate the outflow of aqueous. So they don't have to actually touch the cornea. They put a contact lens which works as an inductor, and with an electromagnetic induction, it stimulates the outflow of aqueous. Then there is another one called the Equinox balance goggles, meant for normal tension glaucoma. This is meant to be worn at night, and it creates a negative pressure to match the CSF pressure. That is also showing some promising results for normal tension glaucoma. And then there is so much in genetics, which I'm not going to talk about. Gene therapy is available now. The most expensive drug in the world is an ophthalmic gene therapy. And there are so many things. So stem cells are also another area. So I think we see that there's a lot of technology coming up in glaucoma. With that, I end my presentation. Thank you.
Thank you, Dr. John. That was indeed a mesmerizing presentation. All that we're looking to in the coming decade, and we've already started with some of them, and I have actually met you and seen how you are using your smartphone to do so many things in the clinic. So next time I really look forward to some of your innovations again. And with that, we move on to Dr. Chitra Ramamurthy, the Chairperson ARC of the AIOS and a veteran speaker. So Dr. Chitra, please.
First and foremost, thank you very much, Calcutta Academy and Chandrima for inviting me here. So without ado, I'll get into my talk. After going on to a trajectory about technology and what is there for future, it's going to be a crash landing as I bring you into day-to-day existence issues. So essentially, when we are talking about a successful TRAD surgery, the story we all know doesn't end there. Is just an indication of the great vigil and caution which you have to practice over the next few months or probably in the lifetime of the patient to ensure that the surgery continues to be successful for the period of time. For this, we need to have an insight that there could be a blood failure which could be very early on, which could happen at a later point of time. There could be a blood leak, there could be blood infections more rarely. And of course, we have to also contend that there could be problems because of just a large infested blood. So then it becomes necessary for us to understand what are the possible risk factors, identify them, recognize them, and try to prevent the occurrence to continue to maintain the anatomical and the visual function. So first and foremost, we need to keep in view the risk factors: a young age, more aggressive response, likelihood of blood failing, a secondary glaucoma, more of those amyloidogenesis and the inflammatory glaucomas, than the others. Inflammation, which could be as trivial as some lid inflammation of a meibomitis, which was missed out, which could also trigger along with other anterior segment inflammatory causes. A previous surgery, we need to know whether the conjunctiva is mobile overlying, not to identify those sites to do a trap surgery. Afro-Asian ascent, of course, we need to be cautious at these. There are certain hereditary presentations in different eyes. Two anterior punch again would have a valvular effect, that is, if only on a massage would there be an aqueous filtration occurring, and that may not be augur good for a bleb, or a true posterior plunge, which would again not be effectual at all, or even a subconjunctival hemorrhage, something as trivial as having more fibrin and heme in that area, could all augur for a bleb failure. Again, we need to know where could the bleb failure occur. Could it be a blockage at the internal ostium itself, or could it be juxtascleral by the sides of the scleral flap, or subconjunctival, or could it be a mitomycin toxicity, and because with it a conjunctival bleb leak, or a necrosis of the bleb, or a retraction of the conjunctiva at that region. We also need to be cognizant that we need to be conscious and understanding of the wound healing response after a trabeculectomy, an early coagulative phase, which could happen intraoperatively itself, wherein we need to see that we do atraumatic surgery, take care of the bleeders, use adrenaline-soaked sponges. Going on to the next phase, the inflammatory phase, where we need to be generous with our usage of topical steroid drops. We might need antimetabolites then. But going on to the third, or the proliferative or repair phase, we have to be continuously going on with the topical steroids, but should be prepared to do needling or 5 injections as and when is mandated. And of course, the remodeling phase, which actually goes on for a long time. The difference between a regular good bleb and a failing bleb is not the epithelium. We need to look at the subepithelial connective tissue. There are clear spaces or loosely arranged tissue in a good functioning bleb, and not so in a non-functioning bleb. So then the next question is, what is an ideal bleb? So it should have microcysts. There should be a little paucity of vessels over the bleb. You could compare it with the temporal and the nasal side and understand that there should be diffuse drainage, and it should be just be a moderately elevated bleb. You could even test the bleb function. An intraocular pressure check is a surrogate measure, but even the appearance, as I had already alluded to, will tell you whether the bleb is good. And of course, whether if you do a digital massage, the bleb gets lifted, and ASOCT will show you the clear cleavage area. So a good mature bleb, of course, we all know is when the IOP is low. But sometimes an IOP in 18 cannot be called a non-functioning bleb, because we don't know what was the starting IOP, which could have been 50. Again, we need to understand what is a bleb failure. It's going to be a flat bleb, a vascularized bleb, it has a vascular ring, it has no microcysts, and of course a raised IOP. It does not lift with distal massage. Gonioscopically, if you look, you'll notice that the scleral flap is not elevated, is actually attached at the juxtascleral area. And then you look at the, if you look at the internal ostium, you would know whether the iris is plugging, or the vitreous, or the blood. Again, a tenon cyst would be a highly elevated bleb. This would be a bleb wherein there has been a good filtration to start with, and then an episcleral fibrosis has set in, and then you need to act differently here. You need to increase the steroid drops. Early stages, you could even give aqueous suppressants, but needling is the final take. So then we need to look more acutely at the bleb grading. The Reggiana grade bleb, as we are all aware, is the popular ones amongst all the lists given, wherein you look whether the bleb is low elevated, or how the clock hour of extension of the bleb area and the vascularity. Again, the OCT and uveum does give us an idea. A good bleb would have a subconjunctival separation, multiform walls, and a hyporeflective walls, which would indicate it's a functioning bleb. But some of the ways which we could sort of prevent a bleb failure is by stopping the topical anti-glaucoma medication a week earlier, if it is possible, stopping the blood thinners. You need to treat all those silly minute inflammations of the lid and the conjunctiva. Preoperatively, if you could even give topical steroid drops for a week. Importantly, do an atraumatic surgery, and post-operatively ensure that the topical steroid drops are continuing aggressively initially and into a maintenance regime, which could even go on for 3 to 6 months. Use our wound modulating agents as and when. Most importantly, we need to ensure that aqueous filtration is happening all the time, which augurs for the bleb success. And of course, we need to understand that that is where the role of the releasable sutures come in. If the filtration is not as adequate, you have the chance of releasing the suture and so that the scleral flap gets elevated and it goes on and the filtration is maintained. But otherwise, you notice something not going good, you should be ready to start with your 5 FU injections, your needling, and or you use a topical mitomycin drops or give injections, whichever suits your practice. Of course, if you have those stationary sutures, you could again release them with magnification or without magnification, and ensure that you do also a digital massage to see whether the bleb is lifting up and functioning. Again, if there's an internal block, if it is just fibrin, you could give a intracameral tissue plasmogen, or you could use a argon laser to lyse it, or if it's iris which is plugging, we could go in early on. If you do a gonioscopy and understand there's an internal ostium block, you could release the iris tissue and then take care of the bleb. You could do a vitrectomy if vitreous is blocking. You might need an internal bleb revision early on. You can't postpone if you do not diagnose it early on. Again, a Tenon cyst, it is so important that we intervene. There have been different papers, some who have discussed just separating the scleral adhesions, some which have discussed needling, some number of injections, some with just one injection, and there have been studies where they have talked about six-month injections. So essentially, what you need to do is, I would believe in intervening as and when I feel that the bleb is not settling down routinely and it goes on to later on. You can first take in, inject xylocaine with adrenaline in that region where you're going to do the needling with your 26 gauge needle, and use the tip of the needle to separate the adhesions subconjunctivally. And as you're separating, you notice that the bleb is lifting up and ballooning, which gives you a clearer indication. You would have done a gonioscopy and you would know that the scleral flap is probably adherent. So you need to excise in that area of the flap margin, then go underneath the flap, scleral flap, and go right up to the entrance of the anterior chamber. And once you have done it, you could, paucity of time and moving ahead, you need to ensure that you reform the anterior chamber at the end of it and then give a 5 FU injection away from the site. Again, you need to ensure that you carry on with the topical steroid drops in a graded manner and also use a digital massage. Now, this was a case wherein the internal orifice was blocked with the iris tissue. So you need to do paracentesis and then go in with your iris, sweep out the spatula and sweep out the iris. And then, of course, the bleb has been malfunctioning. You then go on to doing your needling procedure. Again, this eye is a highly vascularized eye with a conjunctival defect. So that means that the ocular surface is not good. So you need to be generous with the lubricants and the antibiotics, place a BCL, allow the eye to become quiet and settle down. And then after a couple of weeks, after the epithelium has settled down, then you could consider needling and getting more aggressive in your treatment. The other end of the extreme is a low IOP, hypotony. So this has to be also looked at. You need to pick up those blood leaks. You need to address overfiltration. You need to look into hyposecretion or a cytodialysis cleft. So you could just paint the surface of the bleb area and look at the leaking non-stained aqueous, and that would give you an idea. The other picture is a conjunctival necrosis, which is just set in because of the mitomycin usage and the side effects. So we need to intervene accordingly, and it's important. If the leak is, it's a conjunctival buttonhole well away from the bleb area, you could go in and resuture it and ensure that the AC is well formed. If it is a very small leak, you could take a call by placing a bandage contact lens. Again, the bandage contact lens could be smaller in size. If it is within 2 millimeters from the limbus, you need a larger contact lens if it is well away from the limbus. But again, if the anterior chamber is shallow and is likely to become shallower, we need to get aggressive. Go ahead and resuture and ensure that anterior chamber is reformed. Again, an overfiltering bleb, though might look trivial, it can be picked up early on with the low IOP. But what is more important is we need to keep in mind the structure and the functional status. So if it is a shallow anterior chamber, early on, maybe you could do a conservative management, consider an autologous bleb. But if the anterior chamber is continuing to get shallower, we need to intervene. We need to reform the anterior chamber either earlier on with air or C3 effect gas. But there has to be a time wherein you would have to even think of revision of the scleral flap, and Ologen to that extent temporarily had its claim because it used to tamponade the filtration so that you would not end up in this kind of a situation, because extreme scenario of a hypotony maculopathy is not acceptable. More importantly, it could go on to choroidal detachment, and when you cannot hold on to a conservative management, you need to start your treat the leaks, overfiltration, give oral steroids, and then take a time when you would have to decide that you need to reform the anterior chamber. You have to address if it's going on to kissing choroidals. So first you open up the bleb area to know whether there is a leak. Then you need to address that leak, resuture it, ensure that you keep reforming the anterior chamber through all your procedures, because you do not want to have a suprachoroidal hemorrhage occurring on. But again, at some point of time, you realize that it's not helping. Then you need to raise the scleral flap and then punch a deep scleral tissue, and then ensure that you create an opening so that you are able to visualize the choroid, and then drain the choroidal fluid, and then go ahead and close the conjunctiva, reform the anterior chamber, and thus bail yourself out of that difficult situation. Again, there is another extreme where you can see that the conjunctiva is thinning out, is likely to leak. So in the early stages, you could try oral doxy, or you could try vitamin C on a BD dosage. But what is a message here that you do, as we all know, that we would keep the mitomycin sponge deep into the fornices, ensure it doesn't touch the tip of the conjunctiva, and ensure that you use the right concentration and the right duration of time. And nowadays, we could always do a modified fornix-based flap. Bleb-related infections are rarer, but then that has to be kept in mind. It could be because of bleb leaks which were ignored, or the usage of antimetabolites, or an inferior bleb, or excess use of topical antibiotics. So you could catch this by looking at the congested bleb area, a dusky looking bleb, or an anterior chamber reaction. So you need to be with your VR colleague, get aggressive, whether it's topical fortified antibiotics or something much more aggressive. So essentially, this whole talk is a bird's eye view of telling us that we need to catch those risk factors which are there, and if they are caught, if they are recognized, if they are identified, we could definitely bail ourselves from a more difficult situation and manage to salvage the bleb and restore function. Thank you very much. I don't know whether I caught the train, but I kept thinking that I have only 7 minutes to talk.
Thank you, Dr. Chitra. That was indeed a very, very impressive talk, and hats off to you with doing all the femto interlays and catalysts and everything. You're managing blebs, because I generally tell my fellows, we glaucoma people, we are very laid back that way, and I tell my fellows that only half your job is in the theater when you're doing the surgery. The next half begins the next day post-operative, because managing blebs can really take your time. So you're really doing great work, and thank you very much for that impressive talk. We'll come back to you during the question answer and discussion. With that, we move on to Dr. Vanita. If you're ready, you can go ahead.
Yeah, thank you very much. Thanks for the invitation once again. I really appreciate it. Can you see my slides?
Yes, clear. Yes.
Yeah. Okay. So I'm going to talk about primary tube and secondary glaucoma. It's not moving. So why am I talking about it? Because there are greater risk factors for failure for filtration surgery in these kind of glaucomas. They generally tend to have more inflammation, or they tend to have membranes growing over the angle, causing severe contraction, or they tend to have conjunctiva which is scarred, or a combination of all of these. So why do we need GDDs? I think it's fairly clear that in these secondary refractory type of glaucomas, you do tend to have much higher failure rate. And there is some evidence in literature related to that. And also there is some evidence related to the fact that if you've had a previous glaucoma surgery, like a trabeculectomy, then it could lead to failure. Therefore, I set out to see whether or not there is any evidence for this. There are large RCTs involving GTTs, Ahmed versus Bowell study, Ahmed Bowell comparison study, tube versus trap study, primary tube versus trap study. But in the latter two, TVT and PTVT, unfortunately, there are no secondary glaucomas, at least not the refractory ones which have been included. And even in the Ahmed versus Bowell study, when I looked at it carefully, the etiology only included secondary glaucoma about 1/4. And where ABC study was concerned, it did include about 50% of these. Therefore, what they also did was they stratified the results, and then they found that their worst results were in neovascular glaucoma and their best results were in primary glaucomas. So then I looked at the Indian experience. RD, as you know, is the Barwelt 350 equivalent versus AGV at 3 years has been reported by PGI recently. And unfortunately, they have not done any separate analysis for secondary glaucomas as such, but they did find that overall success rate for RD is better compared to AGV. And this reflects my very own experience of RD versus AGV at 1 year, where I did find that intraocular pressure, that blue graph, was lower in RD at a lower medication and at a much lower failure rate, which means success rate was higher. I was really impressed by this particular intermediate results that came out of RD alone from Arvind, where they looked into great details the results in secondary glaucomas, and they were surprisingly better than the primary glaucomas. And perhaps it's because the number of traps that were done were much less. Nonetheless, there is a fair amount of difference in what I have reported as success rate or failure rate at year 2 compared to theirs. And then looking at my data further, I found that I had many more secondary glaucomas that I had included in this cohort of mine, 1/3 of their size. Now, nonetheless, only a few had trap prior to tube surgery. So what I did is I wanted to look at it all afresh. So I included 110 eyes. They were followed up for almost 2 years. Not reported this. This is still publication is pending. The majority etiology, was post-VR surgery and neovascular glaucoma. And overall, if you look at it, it actually looks pretty impressive. But when you split the two, RD and AGV, you find that in RD you have lower intraocular pressure at a lower failure rate and at a lower need for medication. Therefore, I feel we should be doing much more RD, but unfortunately it is vilified a bit because of its non-valve status. So I will try and give you some pearls to optimize tube surgery. What you need to do pre and perioperative is to control pressure as much as possible, inflammation as much as possible, and in neovascular glaucoma, not only to consider PRP, but also anti-VEGF injection. Intraoperatively is where the difference lies, where in RD you have to have occlusive ligatures, judicious use of vents, stents, and ripcord. I will show you all of these as per clinical indication. In AGV also, I would do partial ligatures, especially in uveitis, in aphakics, sometimes in pediatrics as well. And in both, I would suggest that if there's pseudophakic aphakics, you make sure that there is no vitreous, and try and place the tube in the sulcus in silicone oil. I would also use intraocular vents. So let me share a brief video and take you through it. Pearls of primary tubes in secondary glaucoma. All of these cases are primary tubes in secondary glaucoma. Here, for RD, you need to make sure your adjacent recti are isolated. Then you take the RD plate and check that it's patent. Then you occlude it with 6-0 vicryl, and then check again. And then you can place fenestrating vents anterior to it and check for filtration anterior to it. You can also leave these vicryl stents like that. I left a couple of them in this particular case, and you can place the plate under the muscles. When you feel you need a rip cord, you need to feed it through the tube from the one end, and you can then go ahead by occluding. Here I used 2 occlusive sutures and placed fenestrating vents in front of it. Of course, at every stage, I meticulously check. I always check that what I am trying to do has been achieved. In a young patient, in childhood glaucomas, I do tend to avoid rip cords. I instead use many more occlusive ligatures because I want to avoid hypotony and choroidal detachment when a suture autolysis occurs. So when you're using a rip cord, again, the insertion under the muscle remains the same. It is no different to what you would do when you don't have a rip cord. I enter into the sulcus, especially in shallow ACs, in NVG as well. And when you have a ripcord, you place it in the inferotemporal pocket that you have created, and the cut end of it, I don't leave it loose. I tuck it under the patch graft. And then you can close your conjunctiva as usual. Then when you have a belt, say for instance, then the presence of an anterior or a posterior belt makes difference where tubes is concerned or where the choice of tube is concerned. Here in this case, it was posterior. I'll show you in a minute, fairly posterior. And I could isolate the muscle. So Adi was definitely possible in this particular case. Here, now the belt was very anterior, VR surgeon said remove it, and then it uncovered a really ischemic, thin-looking sclera. Muscles were isolated, so Adi was done. But what we did was we sandwiched the tube between two patch grafts, one large, which also covered the sclera, and the second one, which covered the tube. Now, this obviously makes it very bulky, so conjunctiva is short. So what you do is use these scoring incisions to stretch the shortened conjunctiva, and it closes very easily. Here, in this case of aphakic glaucoma, where I'm combining AGV with sclera-fixated IOL, I first take pre-placed sutures, prime the AGV, and then also I use partial ligature. Then make sure that I have a good anterior vitrectomy, followed by markings for the SFIOL, intrascleral tunnel. Once you have made those markings, you enter with a keratome to simultaneously use a needle through the intrascleral tunnel and use the keratome entry for the multi-piece IOL. As you see how it was easily fed into the needle and then brought out and a terminal bulb created. Similarly, on the other side, it was grasped with micrograspers and fed into the needle and externalized. What is most important in these cases, I feel, is because the IOL can become unstable if you go into the sulcus. Here is where I definitely go into the AC. Here there is another phakic uveitic glaucoma where I did a partial ligature and checked for restricted filtration. In OPD, if you have a ripcord in position, you can easily remove if the pressure is going up, and I will show you a brief video where I did it. I'll try and speed it up a little bit for you. So what you need to do, you can see it's in the inferotemporal pocket. What you need to do is just grasp the conjunctiva with forceps, which is what I'm just doing, and then make a nick with scissors, and then use your forceps to grab hold of that ripcord and just pull it out. And you will see the tube emptying. I've used a corneal patch graft in this case, and you can easily see the withdrawal of the ripcord from the tube as you pull it out. So once you've taken it out, obviously the tube is empty and the pressure should fall. So I do espouse placement of tubes in the sulcus as far as possible, especially in PKs. Also in this particular case, status post pythium keratitis, where the patient had therapeutic PK elsewhere, and she was advised a DSEC with cataract surgery. When her glaucoma was uncontrolled on 4 medication, what I did when she came to me was only cataract surgery and an ADI, and we slowly rehabilitated her to almost near normal vision with good control of intraocular pressure. Here, we planned 2-stage surgery in pseudophakic bullous keratopathy, where the first stage, a tube has been placed in the sulcus infratemporally because superiorly there was no space, and in the second stage, a DSEC will be done. I also espouse usage of primary tubes in the sulcus in iridocorneal endothelial syndromes. I've also published on this, and they do well when it's in the sulcus, way away from the growing membrane. And I do wish that I would be referred lesser number of eye syndromes post-trap, because they don't do so well, unfortunately. Then we have neovascular glaucoma, notorious for failures. I prefer tubes and sulcus once again. But of course, if the patient is phakic and no cataract, you have to place it in the AC. Unfortunately, you can get progressive ectropion UV, a very severe case in another patient where the tube actually retracted and completely disappeared. I had to reposition it. So one has to be mindful of all these things. Where silicone oil is concerned, everyone says do an inferior tube. I have stopped doing that. Why? Because have a look at this 13-year-old boy. 2 years later, not only is his tube retracted, but his silicone oil globule covering the tube. And not just covering the tube, it did not block the tube. But unfortunately, there was a huge amount of subconjunctival deposition and his eye became hypertropic. So what I do is actually leave a fairly large tube directed downwards with a lot of intraocular vents. So it never blocks. I have done this now in at least 5-6 patients, and I'm very happy with it. Also, if the patient is aphakic, I will make it direct, look downwards, so it doesn't get blocked. Again, as I said, in an aphakic eye, if you have done SFIOL, leave the tube in the AC. Please don't place it in the sulcus. That might destabilize the lens. So where tubes are concerned, there are certain facts. One is the tube position changes. There is retraction over a period of time, and there is endothelial loss, no matter what type of implant you are using. So have a look here in this eye syndrome. The tube seems to have retracted. You can see over a period of time that it has gone back. In this case of PK, where a tube was placed in the sulcus superiorly, again, the entire tube is now not visible anymore. This is not dilated or undilated eye. It is just, it's got pus and the pupil is fixed. Also, where there is shallow AC, we must avoid tubes in the AC because of the real risk of endothelial cell loss and corneal decompensation. In this particular case of primary angle closure glaucoma, one-eyed patient, I plan to use an extender and reposition it in the sulcus. Both surgery, the patient had trab as well as tube, both surgeries done elsewhere. So what I do prefer is long. When I'm placing it in the AC, I prefer long tubes. Look at the bottom picture. I not only prefer long tubes, I prefer them close to the iris. Why do I do that? Now, where endothelial cell loss is concerned in all the encircled areas, unfortunately, there will be some loss of endothelial cells. But the position of the tube way away from the cornea in the bottom pictures decreases this endothelial cell loss. And this is statistically significant. So I always espouse AC, the tube should be longer. That is better. Avoid the visual axis. So I end by giving you certain key points about GDDs in primary glaucomas, as my experience has been that RD has greater IOP reduction, low failure rate, and lower need for medications. AGV does tend to fail due to high IOP endpoints, no matter what you do. And RD, therefore, may be a good choice and requirement for low long-term IOP in a target IOP in a patient. And I will say that a greater understanding of the non-valve technique helps to minimize the safety-related adverse events that has vilified this non-valve tube. Thank you very much for a very patient listening.
Thank you, Dr. Vanitha. That was a detailed talk on the RD and wonderful experience. You have been doing a lot of RDs. We'll come back to you in the question answer session. There are questions for you. And as of now, we'll move on to Dr. Vibhuti Sinha, sir, for your talk, to share your screen and start.
Yeah. Is the slide visible, ma'am?
Not yet. Yes. Oh no. Yes. Yes. That's perfect. That's perfect, sir. Yeah.
Thank you, Dr. Chandra ma'am, for inviting me and the Kolkata Academy of Ophthalmology. My job is half done, as Dr. Vanitha has already covered the major part of management part of secondary glaucomas. I'll be talking on one of the commoner type of glaucoma, which is post-traumatic glaucoma. And it will be kind of recapitulation of what we have gone through, what we have done in dealing with the post-traumatic glaucomas. So I'll be dealing in under these headings. I'll be dealing with closed globe glaucoma injuries and open globe injuries also, and some of the specific kind of glaucomas. So important thing is to remember that in childhood, below 30 years, approximately 36% of the cases, as high as incidence is as high as 36% of the patients are having post-traumatic kind of glaucoma. Whereas above 30 years, it is very less. So one should be worried once the patient comes to our OPD, a child with a glaucoma, a secondary kind of glaucoma, we should always look for the telltale signs of trauma. And the losses usually occurs when other problems have already stabilized. So that is very important from point of view of management. So it requires a long-term management. Important is to identify type of injuries. Mechanism is very important. So every kind of trauma has got unique kind of management skills is required. And not to forget, uniocular trauma, glaucoma is should always raise the suspicion, and we should always look for the telltale signs of. We should also remember that the closed globe injuries and open globe injuries classification wise is there. And majority of trauma are basically a blunt trauma. Approximately 30% of the traumas are basically blunt trauma, and they always create some kind of trauma, some kind of glaucomatous problem in due course of time. So that has to be remembered. Now, once we know that trauma is one of the major causes of secondary glaucoma, we need to remember that it can occur in the early stages or in the later stages. In the early stages, it can be traumatic because of the trabecular meshwork disruptions, hemorrhages associated, which is very common, and also because of the lens-induced glaucoma. In the late onset, one of the most important thing is angle recession, and later on the patient always develop secondary cataracts and associated problems with that. And in cases of open globe injury, there are other different kind of mechanisms of glaucoma which is occurring. So what is the common pathophysiology? It is because of the direct transfer also of energy, and there is shortening of the anterior posterior diameter as well as elongation of the equatorial diameter, and that is damaging whole of the intraocular structure. We also remember that the 7 rings, and that all the intraocular structures are damaged to some exchange. So I'll be dealing one by one. So in the early onset glaucoma and closed globe injuries, the initial phase is because of the inflammation of the or obstruction of the trabecular meshwork because of the inflammatory cells. So we have to monitor closely. Steroid and cycloplegics are the major stay of the treatment, but we must remember that the initial part has to be managed. And if the IOP is going beyond a limit, then we have to take control of that. Then there can be trabecular disruption also, which can be documented with the gonia. But remember, most of these traumas are associated with the hyphema. So don't do a gonioscopy in the early stages when the rebleeding chances are more. So can be from the hemorrhages to full thickness disruption of the trabecular meshwork, so the cyclodialysis. Now, from where this hyphema is coming, the majority of this hyphema is coming from the small vessels of the major arterial circle of the iris, but lesser from the iris or trabecular meshwork itself, or from the ciliary body also. The incidence is more in males as they are more prone for injuries. They are working more often in the outdoor areas. And peak incidence occurs in 10 to 20 years. And spontaneous hyphema has to be remembered in these kinds of cases. If the patient comes and we don't get any kind of telltale signs of trauma, then naturally we have to rule out the spontaneous hyphema causes. Now we have to remember that the clot normally undergo lysis within 2 to 5 days, and then the rebleeding can occur, and the chances of rebleeding is quite high, as high as 38%. So we have to remember that. We have to do the grading, and we must remember that we have different management protocol for different gradings of hyphema. So what is the treatment goal in cases of hyphema? We have to prohibit rebleeding, control the ocular hypertension, the IOP which has raised, steroid, cycloplegic, and rest is naturally the mainstay of therapy. The acute ocular hypertension may occur in hours due to blockage of angle and inflammation of the trabecular meshworks. And later on, it can also cause pupillary blockage of the angle closure. So these two mechanisms, the early mechanism as well as the late mechanism, has to be taken care of in due course of therapy. So, and we also have to remember that the blood staining is one major indication where we have to do surgical evacuation, as the chances are very high when the IOP is more than 25 or 6 days or total hyphema is there. So we need to remember the occurrence of blood staining also. So what we do aggressive medical and surgical therapy to reduce the IOP, beta blockers and alpha agonists. And surgical evacuation has got a specific protocol, but we must remember that corneal endothelium has to be given a proper lookup during the slit lamp evaluation. If there is any chance of occurrence of blood staining, we must do a surgical evacuation of these cases. So, coming to the late glaucoma and closed globe injuries, the angle recession is one of the most common, and the mechanism is similar. Only thing is there is a kind of disruption between the longitudinal and circular muscles, and any degree of, we have to remember that any degree of hyphema is also associated with the degree of angle recession in most of the patients. So glaucoma may present 7 to 9% of the patients who have had trauma and angle recession. But angle recession, if it is more than 180 degrees, it increases the chances of the angle glaucoma associated with angle recession. So what is the pathophysiology? There is a tear between the longitudinal and the circular fibers, and elevated IOP is more so because of the trabecular meshwork damage. And we have to remember that there is widening of the ciliary body band, prominence of the scleral spurs, and a gonioscopy when there is less chances of occurrence of the rebleeding is there, we must do, and we must compare the one quadrant from the other quadrant, and as well as we must compare the angle from the other eye also. So these things we must remember, as any amount of trauma can lead to these all damages in the intraocular content of the eyeball. So gonioscopy is must. But once you have gone through the phase where rebleeding chances are less, the incidence of glaucoma in the normal eye is also more. These patients are predisposed to glaucoma, and so we must remember to evaluate the other eye also for glaucoma. But before that, before going to the late pathophysiology of occurrence of glaucoma in the closed injury, there is a phase between early phase and the late phase, between 4 to 6 weeks, when everything has become normalized, but the IOP is slightly high. We must think of steroid responders also in such cases, and look into the pathophysiology in such cases. So what is the angle recession management? Beta blockers, alpha agonists, and we must not use pilocarpine. The role of laser is not much very well defined, but if you have something like SLT, you can always try in the areas which is not damaged to reduce the IOP to some extent, but surgical maneuver has to be performed if the glaucoma is progressing. With the TRAB and MMC is having a very good result, and if it all fails, then naturally, as described by Dr. Vanita, we can always go for GTD. So there are other causes of glaucomas also, like Gosel glaucoma and then hemolytic and hemosydrotic glaucoma. These all have different kind of mechanisms, and we need to identify them very minutely. And if we identify them properly, then only we are able to treat them. And then there is lens-induced glaucoma, different kind of, because of subluxation, anterior subluxation or posterior, because of the blockage of the pupil area by the vitreous, or because of swelling of the lenses, or because of the lens capsule has already ruptured. So there are various mechanisms. This is a busy slide, but we need to remember that these has to be taken care of once IOP is increasing because of the trauma to the cataract. Then there is glaucoma associated with the open globe injury, and where we have to do a very meticulous kind of repair, keeping in mind the post-operative complication like glaucoma. So these are various mechanisms, like in the early phases, there can be inflammation. So, and we have to look for the control of inflammation. And if there is osteosynechia formation is there in the larger area, then we can always do a laser aortotomy once inflammation is controlled. If we leave these patients for a longer duration with a flat AC, there can be formation of the anterior synechia. So we have to do a meticulous bone closure as soon as possible, and we have to maintain that anterior chamber reformation has to be done with a water control. Then epithelial downgrowth is one more pathophysiology of mechanism where epithelium goes inside and creates a membrane-like structure over the angle. And these kind of eyes are very irritated kind of eyes for a longer duration, and they actually require surgical removal, otherwise nothing is going to work. And then there is retained intraocular foreign bodies which naturally require surgical removals. So to summarize, I say trauma may cause elevated IOP and glaucoma. We have to remember that even a trivial trauma can cause glaucoma. So we have to be very cautious in managing those patients with the trauma. We have to give them proper guide that these patients require long-term follow-up to just avoid any kind of occurrence of increase in the IOP. We have to also identify the mechanisms. If we don't identify the mechanism, how it is occurring, then maybe we will fail with the treatment protocol and we'll have to shift to the ultimate treatment protocol, that is the surgical treatment. Otherwise, we can manage these cases somehow in the early phases also. And meticulous short-term management is also required. At the same time, long-term follow-up is the key to success. So thank you, Dr. Chandrima ma'am, for giving me this opportunity. Thank you and stay safe. And next week we are going to elect our leaders. So I wish all them all the best. And this is the dream project on which I am working. 50,000 square feet of government regional institute of ophthalmology, under which roof approximately 60 ophthalmologists will be working at a time. Thank you very much for giving me this opportunity. Thank you.
Thank you very much, Dr. Vibhuti. Wonderful. That's a dream project, and anybody would be waiting to work at that hospital. Really looks nice, and the talk was really informative. You covered everything. Thank you very much once again. And with that, we move on to the last, but in no way the least speaker of this session. That's Dr. Murali Ariga.
Yeah, good evening, and thank you, Dr. Chandrima, and thank you, Calcutta Association, for this invitation. And yeah, basically I'm going to speak about the micropulse diode, which is a relatively recent addition to the armamentarium of the glaucoma surgeon in treating difficult glaucomas and not so difficult ones as well. We have all considered intractable glaucoma as hard to control glaucomas with neovascularization, trauma, trachea, uveitis, post-PK, silicon oil, VR surgery related, and all the painful blind eyes due to raised IOP. We've all been treating this conventionally with older generation doctors would remember cryotherapy and then the lasers and then the diode laser. And of course, some have even used ultrasound in certain parts of the world. Cyclophotocoagulation, the routes available for treatment and destroying the ciliary body could be endoscopic or transscleral. And till recently, I have been using, and we've all been using the transscleral, the continuous wave diode laser with the G probe, which has been used with a fiber optic tip, which has a 1.5 mm tip, which protrudes behind the anterior edge of the foot plate and protrudes about 0.7 millimeters. We're all familiar with this machine and the settings. We've been doing this for many, many years till the micropulse laser has come. The standard parameters using the G probe has been about the start with about 2000, 1500 milliwatts for about 2000 milliseconds. And we keep increasing the power till we used to hear a pop or a UVL micro explosion. Then we scale down, we used to scale down the energy till the pops don't come. So it used to be quite painful. There could be conjunctival burns, iridocyclitis, postoperative hyphema, hemorrhage, hypotony, and sometimes even sympathetic ophthalmia has been reported with the use of the continuous diode CPC. The new micropulse actually is a game changer. It has actually changed the way I manage and we all manage the difficult glaucomas, and now we even start treating mild and moderate glaucomas as well. It's a recent micropulse cyclophotocoagulation technology. Denatures the target tissue while minimizing collateral damage. It's applied using a series of short repetitive bursts of energy that effectively confines the thermal effect to the absorbing tissue and applied in a sweeping movement, unlike the previous probe which used to be applied as a spot application and multiple spots and so on. So it's a continuous application sweeping movement, as you can see in the picture. The probe is of course different from the G probe which we were using earlier. The duty cycle of the micropulse laser is 31.3%, so the on time of 0.5 milliseconds an off time of 1.1 milliseconds. So usually we have now been applying it as 80 seconds into 2000 milliwatts on and off. And this is how the micropulse works. It's done usually in the operation theater because it's a diode laser, so we need to administer a block. So you give a peribulbar block usually I give a peribulbar block, and that's the energy setting which you can see. 80 seconds into 2000 is the power. For each quadrant you would be doing that above and below. I mean each semi circle. Let me give you a few examples of where this has actually worked very well in some of my patients. This is a patient with advanced primary angular glaucoma, a relatively young patient with nearly good vision. Intraocular pressure is very high with near maximum treatment, good patent YAG PIs, and difficulty in indentation with occludable PAs all over, and the cupping was about 0.9 with very advanced field loss in both eyes. So the option would have been on normal circumstances to go ahead and do a trabeculectomy. And we did consider the risks of trabeculectomy. We all know how difficult it is to do a trab in shallow ACs, with very high pressures in PSEG. We dread the thought of aqueous misdirection, developing a cataract, having a shallow AC on day one. And so far I have decided to do the micropulse diode CPC for this patient, and ended up with extremely good IOP control in both eyes. And now this patient has been in follow-up with me for almost about 6 months. Pressure has remained under control. The drugs can be reduced from 3 or 4 drugs to maybe 1 or 2 drugs. Definitely, there's a reduction in number of drugs being used for this patient. Another example of another patient with very poor compliance and intolerance to glaucoma medication. So he simply could not tolerate the intolerable side effects of prostaglandin, simply would give up and would not use the medication. Vision is good, 612, 66. Pressure is under control with medication, but simply does not tolerate most drugs other than timolol. The micropulse CPC was done first in one eye. She was so grateful that the drugs have been discontinued. You can see the discoloration around her eye, the hyperemia. Each time she comes in, she would simply say, let me stop this drug. And the only alternative is she is not willing for surgery. Then the micropulse comes in, and it is a game changer as far as glaucoma management is concerned. And of course, I have used many other patients as well. This is a post-phaco trab in which after needling as well, the pressure was high. This is the only year of the patient and the pressure was very high. The patient is still seeing reasonably well, and there's a tube in place also. The tube also started to sort of give a scar there, and the gleb didn't elevate despite multiple methods. The only option is to put in one more tube. Then I offered to do the micropulse CPC, and it has worked well in this patient as well. The last patient I'm going to show you today is another patient who had a bilateral Boston K-Pro after the chemical injury and multiple treatments and so on. Uncontrolled glaucoma. The only way of looking at this patient was to look at the discs, and the pressure was desperately high, and we need to do something in this patient. This patient also has stabilized the pressures, and the glaucoma has stopped progressing when I have done the micropulse cyclophotocoagulation in both eyes. Some of the problems that you face with the micropulse CPC is the cost and logistics. The machine is expensive, the probes are expensive. A single-use probe which will last for about 90 minutes only, so you need to pull together a few patients for you to optimize the use of the probe. A mild fibrin reaction you can encounter. A vision loss of 1 or 2 lines has been noted in some patients. Pupil can remain dilated if you don't apply the correct method. Pain, redness, and epithelial haze can happen in a few patients. An extremely rare choroidal or hypertony can occur. And you should try to avoid treating areas of thin sclera, blood clots, and recent post-op patients. So definitely not do the micropulse. Plenty of literature available. Survey of Ophthalmology, Academies, Ophthalmology Publications, Journal of Glaucoma. A lot of literature available, and all recent journals. Excellent results by most of the authors and groups which have looked at this particular technology. Many companies also make this particular machine and the micropulse method. Our own study results which we published, sent in for a paper at the ICGS this year, and this looked at our experience with the micropulse CPC. We find that at the end of about 6 months, a 30% drop in intraocular pressure from the baseline. Number of drugs have definitely reduced from 3.3 to 1.6 compared to the baseline. So how does the micropulse CPC act? The subthreshold cell damage at the level of the pigmented epithelium with no visible scarring and reduced collateral damage. Suppose to have UV scleral outflow increase through the extracellular matrix remodeling. And of course, some people believe it even acts like pilocarpine. And no anatomical damage has been reported and has been shown in some of the publications. This is a picture showing you there is no change in the UBM, as well as shows a thin space which may actually correlate to the presence of a suprachoroidal fluid after the laser is applied. So take home message, micropulse CPC, very effective, safe alternative to continuous wave diode CPC. Can be used in even mild and moderate and even advanced, of course, advanced glaucomas and eyes with good vision and not just intractable glaucomas with poor vision. And they definitely reduce the need for medication and very few complications as compared to the continuous diode. But you should avoid in eyes with recent surgery and inflamed eyes, better to avoid. Of course, we need to look at the long-term effect of this in the next years to come and see how long will effect will last and how long the patients can remain with reduced medication. We can just show you a short video clip of the procedure for you to appreciate how it is done. In the theater with a microscope, block is administered, and pretty simple as far as the timing is concerned. Hardly takes about 2 minutes to do the procedure after the block is applied. Make sure a good block is administered, and patient should be comfortable to apply. This is the probe being applied. You can make the markings and apply it. The superior one is moved in a sweeping fashion for about 80 seconds, and about 4 to 5 sweeps if you're going to sweep about 15 seconds per sweep superiorly. Try to avoid 3 o'clock and the 9 o'clock is what is generally being said. But I also tend to apply over 3 and 9 o'clock because I don't really find too much of a problem. Thank you all for your attention.
Thank you very much, Dr. Murali. And as usual, that was a great talk. And the keynote speaker, Dr. Lahane, has just joined in. So I'll move on over to Dr. Lahane for his talk. So are you here? Yes, sir. So can you unmute yourself? Yeah. So please unmute yourself. Sir, please unmute yourself. Sir needs to unmute himself. Can you tell him? I'll just call him and tell him, I think.
Yes, ma'am. Hello.
Yes, yes, sir. Go
Chandrima, thank you very much for just calling me and inviting me. I can see this Murli, I can see Rahul, I can see Chitra. Good evening. I can see the Parihar. Hi, Parihar sir. How are you, Surji?
Hi, thank you, sir. Thank you very much.
Good evening. Good evening. Good evening. I'm sorry, I was in the meeting, and see, I am not a glaucoma doctor. I only treat very less, maybe 2,000 cases per year. Not treating much cases here. Where I treat the cataract 2 lakhs cases per year. But see, the glaucoma I am treating, and the Chandrika told me ki you must present. So now I'm not an ophthalmologist. Now I am a covidologist. So whatever from the, you can say, 19th March, what I am doing is treating the COVID patients. So then here also they are given me the topic to talk about the COVID patients. So I think I will require permitted. We said okay, very good. The share is permitted, and now I am going to speak to you on the covidology. See, this is the COVIDs, and in the COVID what we can do, that I am going to tell you. One is this. Once upon a time, this was this was the luxury, and today this luxury is not at all there, and there is no hope of this luxury. I don't know how many years. There was no COVID, and now see now there is a COVID. So one person. So like Western, now we are alone. Whatever you want to do, change is the only constant thing that happens, that we'll have to do, and for the people and for the doctors, for both we'll have to change. Now here for the people, you will see like this, they want good habits which we are doing forcibly today. See, this was our habit, and now what is happening, that this is forcibly should be implemented in us permanently. We will have to implement, otherwise, because now we will have to live with the COVID. That is what is the mantra today, because we are unable to calculate what is going to happen. So not this, but yes, you have to go alone anywhere. Also in the house, you must eat, drink only single. Now see this, when you will be this picture again. So now this picture will be again, if there is a vaccine, then this picture can be seen. And they cultivate good habits, oral hygiene, cupping and sneezing and wash. The disease burden will reduce in the country if our habits are good. For the doctors, change we need in medical care we provide. To begin with, appointment system, very, very important. You will have to give the appointment detailed history before giving any appointment. Without history, you will not give any appointment. Now COVID and non-COVID, both histories are required, and here the demographic details, because now everybody knows where is the hotspot. Then the name, age, sex, address, travel history is very, very important. And in the COVID family or relative or friend. So is it there? Contact and exposure. You will have to ask complaints of duration of symptoms, this systemic illness diagnosis. In case of the follow-up, you require this. Now request them to download Arogya Setu. Very, very important app, and send you the screenshot of these evaluations. Now Arogya Setu, you are safe, moderate risk, and you are at a high risk. So if it is a safe and moderate, you can give them appointment. If it is a high risk, you will not give them appointment. Otherwise, all people working in the hospital will get infected. So then what is to be done? Send them to COVID hospital, because you know the COVID hospital, send them. Now tries, you'll have to see this appointment diary. Now here you will have to see the appointment diary. Monday, conjunctivitis, trauma, loss of vision, diploma, decide. You'll have to classify. And after that, Tuesday, then you will have to go for mature cataract, glare, halos, then the high myopic refraction. Wednesday, you have to go for retina screening, refraction, and the fixed number of the patient. Very, very important. Number of the patient should be fixed time, minimum investigations, and trials day-wise. Otherwise, as per the severity of the disease. So that is very important whenever you are. Now what to do when you have walk-in patients? Now what is regular checkup? Take detailed history, provide the appointment. If you are full of day, then you give appointment. Emergency, high BP, unconscious, seizures, then history to be asked to the attendant. Treat as a COVID if there is no history provided. Now here it is the emergency room, and also emergency trolley required, though you are ophthalmologist, because when there is a cytokine storm, within 6 hours patient dies, and then they will say that patient was in the hospital but there was no bed. So that should not happen. Patient who needs emergency management should be treated in the separate chamber. Wear PPE and then only go ahead with the management. Without PPE, not a single patient to be seen. Train as an assistant for the same, and that is very important. Assistant should be trained. Now see, don't be casual. Now what happens, we are so many times we are casual, and even in emergency you should not be casual. Use gloves, means use gloves, very important. Then what to do when you have only walk-in patient, then now and illiterate patient, then what you have to do is keep a phone outside clinic, and no patient's complaint before patient enters in your clinic. There should be outside one clinic, the phone, full equipped trained assistant, and who can evaluate patient before entry in the clinic. That is very important. Now see here what is required. Patient history, then temperature evaluation, and the declaration by patient. Very, very important that we will have to take the declaration by the patient. And then wash the hand at the entry, that patient should wash the hand. No entry without mask. He may be anybody, he should come without the mask. And then spacing. In OPD, there should be 5 feet distance between 2 patients, which is mandatory. Rearrangement. Make multiple workstations to minimize patient contact. So workstation should be more, so that we can minimize the patient contact. And then BP primary checkup by assistant or staff. Then you can see the doctor's cabin. No patient should sit more than 10 minutes in your cabin. because after that he will get the contracted infection blood test separately. Then the prescription they should collect from outside. So whatever patient, when patient goes, whenever patient is there, don't write the prescription. Remember whatever the patient is saying. When patient goes out, then you write the prescription, so that the time, the contact time of the patient will be reduced. Because you know, though you have got the mask, after that also chances of infection are there 5 to 7%. So it is very important that the contact time should be less. Reduce total patient time to minimum. The telemedicine, yes, because now the India has permitted telemedicine from 22nd of May, and it has also appeared in the Gazette of India. So you can treat patient on telemedicine. So follow-up can be done only on the telemedicine because you know the patient. Now this is what I want to tell you, that small things, then but very important. And other thing is temperature. Each temperature should be from Kuresh, I will call you. Temperature should be 20, above 24. Humidity should be 40 to 70. Cross ventilator should be adequate. Otherwise, don't use the AC. You can open the windows, and that is very important. And exhaust fan at the windows. That will help you. If there is that create negative pressure inside the room, so that the spread of infection will be reduced. Now biomedical waste management is a rule, and we will have to manage this biomedical waste, because see what happens. The color coded are there: chemical waste, human and animal anatomical waste, solid and sharp medical waste, plastic waste. That is very important, that whenever you are managing the biomedical waste. So this is very, very important when you manage. There are two types of ophthalmologists at present. What is the ophthalmologist? I want to do routine surgeries. Other person, I am doing routine surgeries. So this is what two types of people are there. And if they are there in this, then you know, if you are doing routine surgery, what will happen. The second is do the routine. Other thing is, but with caution. Whenever you are doing any routine surgery, you will have to take caution. Without caution, if you are doing routine surgeries, that can trouble you. Other thing is operation theater, minimum OT list. So now here, and you will have to also give the appointment according to the time. So gradual increase, keep adequate staff, not in excess. So what happens, there is so much of the staff because they are not having now the job. So they want to work. So ask them or give them pay if they are not coming also. But don't call them in the hospital. Time out between OT cases. So between OT cases, there should be 30 minutes to 1 hour time out. That is very important. Otherwise, one person will give rise the infection to the other. Special concern of the high risk by every patient. Because you don't know that patient is having COVID or our one of the staff is having COVID. So that should be where the patient should be made aware that you may contract infection from our hospital. So that he should be made aware and in his language, and after that you can operate him. And the disease contraction from the patient. The COVID testing pre-surgery, when you will do pre-surgery means if you are doing this test, within 3 days you must operate. Because that time patient is not, you can say infective. But if you have done the test 4 days before, you cannot operate the patient. So test, whenever patient to be posted, he should get tested and then come to you. COVID test of each patient posted for OT, and then treat every patient as COVID, irrespective of any test. So you should have all PPE kits. Without that, you should not treat the patient. Now, what responsibility we have as a hospital or clinic owner towards our staff? What is the responsibility? Because legally they may ask us. Education is our responsibility. COVID, contagious disease, education, and when they have attended the training, their signature. And there should be minimum 3 training of each and every person. 3 training, 3 times they should be trained, and their signature should be there. on your register that they were trained, and you will have to also write, or if possible, there should be video whenever you are training someone. Small video you can keep as a record. Other thing is replace the fear in mind with the alertness. They should be made alert that yes, we can avoid the COVID. That is, we will have to encourage them to get insured with health policies. Health policies is not our responsibility. Encourage them or support them by loan. So, but health policy is very, very important. Then keep the positive attitude and environment in the hospital. Attitude should be positive. Important thing is, together we can, but we should be away from each other. We must work for each other, but we should not be together. Away from each other, for together. That is what should be the thing now. And other thing is Hippocratic oath. Here what we say, that rule, do no harm to yourself and patient also. That is very important. Avoid the harm to everybody. And do not harm patient and yourself to stay safe. Very important. I also request everybody to stay safe. Thank you very much. Thank you, Chandrama madam. Thank you very much.
Thank you, sir, very much. That was indeed a very wonderful talk. You really woke us up to the present situation, and whatever we were following, we are going to follow everything now in a more intense manner, because you're dealing with one of the worst states of COVID. And I and the Kolkata Academy of Ophthalmology are immensely grateful to you for sparing time to come and talk to us this evening in spite of having your busy schedules. And thank you very much, sir. Thank you. Thank you very much.
Thank you. Thank you very much. Thank you. Thank you, Chandrama. Thank you. Thank you.
Thank you, sir. With that, we'll move on to a little bit of the question answer session, because there are a lot of questions actually pouring in for the speakers. So I'll just ask one question which came first, and I think Vanita, are you here? Dr. Vanita?
Yeah, I'm here.
Yeah. So Dr. Vanita, this is a question for you. How well does the ADI compare with the Bavald? You have the experience of both.
Yes, I do have experience of both, and I will say that although there are not many, I'm actually only aware of one study which came out of King Khalid Hospital, Saudi Arabia. A very small study of 25 cases each, I remember, and it actually compared very well. I feel I get the confidence to use ADI only because I have experience with Bawel, and Bawel too, is as has been shown in various studies, fairly superior to AGV, where intraocular pressure control is concerned, where lesser number of medications are concerned, and where success rate is concerned.
Fine, Dr. Schmidt Chaudhary, please.
We have Dr. Major Dr. Padiha. You have a lot of experience of all the GDD valves, and your experience.
I have not used ADI too frequent. Initially, I have used, and the Kolkata has taught me valve in 2002, 2003, 4. I started with Molteno and Barwet, and subsequently I had switched over to AGV. Regarding my experience, for last 10 years, for almost all cases where filtering surgery is required, I am doing primary AGV in all cases, whether it is a POAG or more than 3 drugs, or angle recession glaucomas, traumatic glaucomas with scleral fixated IOLs, or NVG, that remains my choice. And almost more than almost 1800 valves, probably I would have had a problem with the valve. That number may not be 20 odd or so. So I'm quite happy with the results, and I strongly feel that we are treating glaucoma not for today. If the patient is 50-year-old, I am intent to give him a controlled intraocular pressure without or with one adhesive. Fields are stable for next 20-25 years. And for that, primary valve is the choice for me in all these cases.
Thank you, sir. There's a skills there, primary track of primary valve in our country at this correction option. Anita, want to say anything? The primary track of primary valve.
I will say if it is a primary glaucoma, I will definitely give TRAB a chance. And I will give it the best chance. When I say best chance, you know, I actually, being a referral center, unfortunately do tend to see the worst spectrum of glaucoma, very advanced glaucoma. And so I tend to do my TRABs with injected mitomycin C. If required, I use injected mitomycin C with Ologen. I do not do Ologen on its own. I tend to do it in younger patients where failure is higher. I'm trying to compare that now. I'm looking at my figures. I would do it topically. I do all my TRABs, I would say almost 100%. Well, I should never say 100%. 98, 99% TRABs I do topically. I do my phaco TRABs topically, so I protect the nerve as far as possible. I hope following them up over a period of time, you know, I will be able to keep the visual field stable. But where secondary glaucomas are concerned, my mantra for a very, very long time has been primary tubes in secondary refractory glaucomas, which have not received TRAB before. I don't like doing TRABs in secondary glaucomas. I do tend to do primary tubes in such cases.
Yes, in these cases, I want to say just one here. Just one player.
Mona Prana here to join.
Yes, I'm here. I'm unable to turn on my video actually. I think the connection is a little weak.
Okay, you can say.
Yeah, so yes, tubes are a very good option in secondary glaucomas. However, in my practice, if there is a good conjunctiva available and other risk factors are less, we do give TRAB a chance. And in fact, even in neovascular glaucoma, if in these cases, actually the conjunctiva is very good because they've been exposed to the IOP lowering medications very less. But if you can give some anti-VEGF into PRP and then you can do a TRAB also has a very has a good success rate. It is a fairly equal success rate provided you can control
sorry, can I just say, but we don't see that evidence in literature, especially in larger studies. We don't see evidence of TRAB being more successful.
Not more successful, equally successful, I'm saying. It's not better or worse. The results are similar. That's what the WGC guidelines also say.
No, they have said it is not decided. I don't think they have said for sure that you could do
superior. Yeah, it's not superior, but it's fairly equal. So it is an option. You cannot rule it out.
Debate stays.
Yeah,
TRAB or tube. But one thing is that
what I'm trying to say is when we do a TRAB and it fails and then move on to a tube, then the chance of the tube failing also is high. We don't see it that way. The tube, especially the more widely practiced tube, is the AGV. And if you see in AGV, if you've done a TRAB, unfortunately the fibrosis that happens around the plate is very significant when you've had a previous TRAB. So the chance of failure of the tube also becomes very high. So I think, you know, one should be seeing in terms of what is going to make, you know, what surgery doing the first time, always thinking that you have only one go, only one chance. What surgery is going to do? Of course, Murli will say that.
I was just going to say something.
See, I have a little bit of experience with micropulse diode, and I have used in fairly horrible type of glaucomas as well as in eyes that see. What I have found is that at a year, I have followed them up for a year. What I found is that it does reduce medication, but it does not reduce to a great extent. It does reduce pressure, but not to a great extent. So if you're just looking for reduction in medication, it's an excellent option.
Yeah, Dr.
When
Padiha,
you have reached, when you reached the end, more or less you reach the end road.
Dr. Padiha, you want to ask something?
Yes, yes. I want to, what she said, that reminds me of my Kolkata days. I was operating on the patient and he was a footballer, Mr. Ganguly. So it was a FECO case. So I'm linking here. I had asked him, sir, how do you feel? He said, I am feeling that I am from the Mohan Bagan and having the match with the Mohammedan club, and it's a bumpy ground with the rains and all. So playing, and the same for the cricket, if you are playing at the ground which has a rains, and after that you have the ball will have a uneven bounce. The same thing happens with the trap, and if it is the trap failed and you are doing the AGV or any wall, it is something like that playing on the bumpy ground. So it is always better to have a Eden Garden which has a lot of scoring of playing 600 runs, so that Eden Garden will be available when you are doing the primary tube surgeries.
Okay, the next question.
Would you want to say something?
Yeah, actually, between the tubes, let's leave the micropulse aside for the time being. I think I have started doing micropulse more for the primary angle closure glaucomas and the bad ones where I don't want to do a trab and so on. I've done tubes and then nothing works, the laser works well. But between the RD and the AGVs, I have done enough AGVs for the last 10 years to know that the pressure control is sometimes not adequate. You get this bad encysted blebs and you simply just don't know how to deal with this encysted bleb following the AGV and so on. And I have not done too many of the RDs, but I find the RD is fantastic. The RD is really probably the answer for a good tube if it is done well. I think all of us here in this panel are all the so-called glaucoma experts who have enough experience with the tubes. So tubes are good when you know how to handle the problem, covering it up, and all other complications and so on. But for the average general ophthalmologist, I think suggesting a primary tube is probably a little some kind of an overreach, because not everybody can successfully do a tube primarily. So maybe trabeculectomy is probably something in between for a general ophthalmologist to deal with, rather than simply saying you must go for a primary tube in even primary glaucomas. So there I think I would differ with Professor Parihar that doing a tube for a primary glaucoma is not maybe a suggestion from our panel to a general ophthalmologist, but for a secondary glaucoma, yes, I think you refer it out to a person who does the tubes well or the laser.
Can I bring in Dr. Sharmila here?
Yes, madam. My indication for tube would be typically for secondary glaucomas, most importantly neovascular glaucomas, post-PKs, NIs with post-traumatic aphakic and things like that. But I would definitely give it a chance for primary glaucomas to go first for a trap and then maybe wait for it and then see with mitomycin, with high dose mitomycin, call to the duration and wait and see and then go for a tube. I wouldn't go for a primary tube in eyes with primary glaucomas. Essentially, it's only reserved for secondary glaucomas.
Dr. Mukherjee.
Yeah, probably I'm representing, are you, is okay. Can you listen to me?
Yes.
Yeah, just probably I'm representing a group of ophthalmologists, general ophthalmologists, who does take care some amount of glaucoma in the very periphery. For those patients who do not have access to reach to the real so-called glaucoma specialist working in a city setup. So if you think that the valves or the tubes are the primary surgical option for glaucoma management, then what should you do? How will you manage this a cost-effective base, putting a valve and expertise, of course, than to do a trabeculectomy? If my patient, if a failed trabeculectomy reaches to you, what will be your concern? How can I help those poor people who are working who are in periphery, cannot have access, doesn't have enough money to go for this type of treatments? What should you do? I know it is possible to go to the district hospitals or medical colleges in West Bengal. I know the scenario, but they do not have any other way but to stay with me. Whatever what I am doing to them is best for them.
But one thing is that Adi has changed the scenario as per the cost is concerned, because the AGV one is available is very costly, whereas the RG is a much cheaper one with the 4,000, 5,000, within 5,000 getting it.
But I would suggest that Adi is actually the more, has more safety issues. So, it is not something that I would recommend for a general ophthalmologist to do. As Murli was saying, yes, TRAB, many people have done TRAB, continue to do TRAB, which is, I suppose it's fine, especially in real outreach areas where affordability, accessibility, everything is a problem. So what I would suggest is, under the circumstances which Dr. Chitra has very nicely said, if a TRAB has already been done and it has failed, you can give needling a chance. Needling also is vilified in our country. I don't know why. I feel, at least in my hands, I feel if I have a failing or a failed TRAB, I get about 7, maybe 8 out of 10 working again. And if that is the case, it is a very cheap thing. You can do it on the slit lamp if you are so well versed of doing procedures on the slit lamp. You can do it in the OT also. It's completely your choice. That is immaterial, but it only needs a needle, and it needs either 5-FU. I use MMC, both of which are fairly cheap drugs in our country. But one has to learn how to administer it correctly and to do the needling, and choose your needling also properly, of course. You don't let a TRAB fail for years and then suddenly you start doing a needling. The moment it starts failing, you start acting. This is what I think the message that Dr. Chitra gave very well.
Needling actually works best in failing blebs than failed blebs. Yeah. So Dr. Rashmi, would you like to say something? Dr. Rashmi, Dr. Vineet, Dr. Medha, do you want to add something to that, or we'll move on to the next question?
Yes, whatever Dr. Murli, Dr. Vanita has said, totally agree with that. Like for a general ophthalmologist, TRAB works well, and RD definitely needs some more expertise, and ADV is relatively easier, not like as TRAB, but it is easier compared to RD. RD needs little more expertise, especially in the post-operative management and also intraoperatively to identify the muscles and all. So definitely that is not for someone who is not trained under a surgeon who has done it. And TRAB and bleb needling, definitely it works really well initially for primary glaucomas.
Just one point about needling. I think if a bleb has worked well initially for the first few months or years and maybe even longer, and then starts to fail, that's when the needling is more likely to work. Initially, if the bleb has not worked at all, then there's no point in going on needling a scarred bleb and so on. So if it has worked well initially and you had the bleb coming up nicely, then you can start to go back and needle. And I think it's a real knack to understand how to needle and when to needle. So not everybody gets a knack, and it doesn't work very well in everyone's hands. So I think that's definitely a clinical judgment, and we do have to definitely give needling a chance. I agree with you, Vanita.
And that's a learning curve also, I think, needling. A little bit of a learning curve.
If you have done a TRAB, I think we should try needling before we do any other second.
If your TRAB is very good, probably a learning curve of needling will be not required at all.
Yes.
No, that is not true actually.
Why?
However good a TRAB you do.
No, I'm saying learning curve of doing needling.
Okay, learning for needling, yes, sure.
That's
if
right.
You can do it, yeah. So the idea is to recognize which ones will work with needling.
Yeah, yeah.
If it's a really angry bleb, flat bleb, a needling is not going to work there. There possibly you need just 5-FU injections weekly. So there are ways and means of approaching a bleb in a systematic fashion to start getting it to work, or at least make an attempt before you move on to more invasive surgery later on. Because if I have a TRAB and I've done a needling, and if it has failed, my next step is a tube. I don't do anything else. I don't do a second TRAB anymore. Long time.
I just want to add one thing. I have a lot of experience in AGVs. Before that, I was doing Multino for almost 10 years, and last 15 years I'm doing AGVs. So the thing is that there are certain patients who actually teach us. So what happens is, like I was doing, my video is blocked by co-host. So only audio is there, I think. So,
Ruchi, you blocked her video. Why?
No,
Dr. Medha.
We'll just check. We have not blocked because her video was not even come earlier also when she joined in. I'll just see.
okay. Okay, I can just stop, no problem. The thing is that I have a varied experience. Obviously, like Dr. Vanita said, I won't be doing AGV primarily, apart from certain cases of secondary glaucomas and obviously NVGs. I had a juvenile glaucoma where someone else had done a trabeculectomy with MMC. Obviously, the conjunctiva was like all cystic and it was failing. So I did a AGV after that. And the AGV also failed because of this. It was a lot of tenons surrounding. I dissected tenons, I punctured the tube, I put ologen over the punctured tube. No, it used to work 6 to 9 months. And after that, again, pressure used to go up slowly. This happened for almost 2 to 3 years. And after that, where the mitomycin was done, fortunately, the conjunctiva started feeling, I thought that it's becoming healthy. So after first trap with MMC, the second AGV, and then again the ologen over the tube where it was punctured, I tried a trabeculectomy with ologen with MMC at the previous site, near the previous site. And then this worked very well. So we really don't know what is wrong, but apart from our experience for so many years, we know that, okay, trabeculectomy, if you do properly, with proper selection, with MMC or ologen works very well. AGV has to be kept as a secondary procedure for these patients, but obviously if there is secondary glaucoma or like patients like NVG, where we know that trabeculectomy is definitely going to fail, then the AGV works very well.
Can I just say that, however much you followed up a patient, in the life of a glaucoma patient, it just goes on and on and on. So you never know when your next surgery is going to fail, and you have to be prepared for that. So right now, your second trab is working with MMC and ologen, and fingers crossed it will continue to work. But we just have to keep a watch.
Yes,
at the end of the day, this is what glaucoma is all about.
Yeah, you have to keep following these patients for a long time. Like, that's
one more thing I would like to add. Like I have seen Dr. Vanita doing so many bleb needling. Even needling doesn't work well in all the hands. Ma'am's hands, it's like the needling works really well. But I have tried many needling, but it doesn't. My needlings don't do so well. So I got a second repeat trap or an AGV. So needling also maybe needs some exercise, and also it works in few hands like Dr. Vanita.
Hats off to Vanita.
No. Thanks very much. It's very kind of Rashmi to say that. She was a fellow when I was just about leaving, and then she joined as consultant. But what I say is that, the knack is in deciding which one will do well, rather than, the needling per se, which is what Murli was alluding to.
That's experience, which blade will work.
Everyone gets experience at some point of time in their lives, We don't get younger, we only get older.
Can we get to the next question? It's for the Chitra. Dr. Chitra, please. Just the blade leak. Now we have seen the blade leaks numbered and getting less day by day. What? Leaking blade. Our experience of the leaking blade at this present era, what we were seeing before. Because at one time we used to see lots of leaking blade and complications of the trap side. Now it has come to a lower level. Can you say what may be the cause?
Must be definitely a lot more atraumatic careful surgery and attention to details, but also the way we place our mitomycin well away from the edges of the flap and deep into the fornices. Those things are schooled into us from the beginning. So the earlier when I started trap and in my early days, those things were seen here and there. But I don't think those kind of issues happen nowadays, because there is a lot more thoroughness which has come up into every step of the surgery and amount of information which is thrown around. I don't think bleb leaks are common at all.
Shumita, do you mean early leak or late leak?
What? Whatever.
Early leak is less.
Early leak is less something. It happens to everyone, but the late leak is the problem.
Late leak is, yes, that
Late leak is the
that
problem.
or
See,
where
that's when people have learned how to use mitomycin more carefully and in a few fashion, not in a localized fashion. And so, but even then I will set up a manuscript on late leaks, and on my own have a series of 18 patients, 89. So not all my patients, 5 of them were mine. So, even if you follow them up for long enough, you will find that some of them probably have become thin because blebs keep remodeling throughout. They don't stay static. Yeah, it can happen.
I think we have learned how to use mitomycin, and the dosage of mitomycin has changed a lot. We were using 0.4 for 5 minutes, 0.4 for 3 minutes, and now 0.2 for 1 minute to 3 minutes depending on the condition. And we also know how to apply it. So all the sweating and the so-called leaking blebs are all sort of history now, at least with most of us, because we know how to optimize the use of the mitomycin, the dosage, the duration, and the way we apply it. So I think definitely matters, and hopefully I think we get more experience with using mitomycin and less of the problems which you used to face before.
So also what Dr. Chitra was saying is the use of the instrument. The meticulous use of the instrument, not sharp instrument. We use the blunt instrument for holding the conjunctival and all those things. And change the scenario of the trap also.
Dr. Chitra, there's one more question to you. That is, what is the topical antibiotic that you prefer in leaking blebs?
I would definitely use a more recent generation, the Moxiflox or something like that is what I would try to use for a leaking bleb. And if I'm suspicious of a bleb infection and all that, then I would be very, very vigilant with these bleb, because bleb leaks are not, early bleb leaks are quite rare now. So if there is a leaking bleb, I would be very aggressive about antibiotic usage. I wouldn't stick to ofluracin. Like I could consider that as a pre-op prophylaxis for a routine cataract surgery if at all, but not for trap. I would be more.
Okay. Any difference of opinion in that?
I think probably the question refers to the use of, some people use aminoglycoside antibiotics, thinking that they can sort of help scar the bleb a little bit and reduce the amount of filtration going through thin-walled blebs. So I think the question refers to the use of gentamicin or tobramycin for that. More of inducing fibrosis rather than for antibiotic that antimicrobials. So I think the question means that.
We need to be careful with aminoglycosides in our elderly patients.
Yeah.
I think definitely the practice of subconjunctival aminoglycoside should be discontinued because of its toxicity to the retina and specifically to the macula.
I think we should not hesitate to use a bandage contact lens as in
absolutely.
And let it be there for a couple of weeks, not be in a hurry to take it off too. So these itself could be a small solutions.
Actually, if you ask me, I sort of almost 100% use bandage contact lens, not for leaking, but it gives a nice diffuse bleb morphology, nice thick walled. So
diameter?
Diameter should be, particularly the 15 millimeter. 15 millimeter BCLs are working nice.
Yeah, bandages actually work very well. That's true. I also agree.
Yeah, so I almost routinely put it in. And it also keeps the patient very comfortable. So they are not, squeezing their eyes. They are, day one. Actually, I do topical, so I see them on the same day. They don't feel as though any major surgery has been done. There's a downside to it because then they don't look up to their eye sometimes that well because they don't think a major surgery has been done. But yes, I do like using bandage contact lens. It's part of my trachelectomy management now.
How many days you want to keep it?
Minimum about 2 weeks.
Okay. So, next question is very interesting, coming from all the way from Calicut to Calcutta, from Dr. Bindu. She's asking that whether after micropulse has been done, whether that eye can be operated for phaco trap. This is to Dr. Murli Ariga and to all the panelists.
Okay, so actually that's very interesting because actually I sometimes do a cataract surgery after doing a micropulse, same sitting in the theater itself. I first do the micropulse and go ahead and do the phaco at the same time. I've done that in at least about 3-4 patients so far. And I also do the sometimes in neovascular glaucomas, do the laser and do the intravitreal injection as well at the same time. You just have to ensure that the probe is sterile, and probably the first patient in the list, you do the procedure for the sterile probe. Go ahead and do the sterile procedure. I think there's no big deal doing the phaco immediately after the micropulse is applied. And after the micropulse is applied, yeah, after that I think probably just give a week's time or a few days time. Suppose you get some little fibrin, you may get a little fibrin reaction after the laser. So maybe you can even do it as early as a week if at all you want to do a phaco. I would not necessarily do a phaco trap because your pressure is usually well controlled in about 70-80% or even higher percentage of patients. The pressure gets controlled adequately. So probably trap you can do with a little caution or may not be necessary. Phaco you can definitely do earlier.
I have a question for you, Murli. I'm sorry. When we are reusing the probe for 90 minutes,
yeah,
is that what is recommended by the manufacturer? Is this the practice that is being done in the West, or
this is the same probe that's available throughout the world, and it works for 90 minutes. And what I have done initially, we were over enthusiastic and we were using it for 6, 8, and even 10 patients. The highest number I have done is about 8, 9 patients. So the timing and logistic becomes a problem because you need to give a block, get them in, get them out. Now the NABH and all kinds of things. So I have optimized to maximum of 3 to 5. 3 perfect, 5 suitable. And what can happen is I found that suppose using it for the 6th time or the 7th time, probably the efficacy of that delivery of the laser through that probe is maybe a little less than the first time you're applying the laser through that probe. So I don't do it more than 5 now. And I've asked the manufacturer many times, but they keep claiming that it works equally well till the end of the surgery.
No. What I'm trying to say is that the same practice in the West as well?
Yes.
They use multiple eyes?
Yes. The probe
they use it
timed.
multiple times.
Yes.
Okay.
The probe is timed for 90 minutes.
Murli, do you have any idea how this compares with the UCP, the ultrasound scleroplasty?
Frankly, I don't know. And there are a few people using it, I guess. And
I do the ultrasound scleroplasty, and what I saw from your video, it's almost the same procedure, except that in the ultrasound scleroplasty you have that docking. You need to do that docking just like we do in the femto. When we do a femto catalyst, we do that docking. The same thing in the UCP. You do the docking and the vacuum is created, and then you pour in water just like you do in the femtocatalyst. And then you selectively do the scleroplasty depending on your IOP and field conditions and all that. Sometimes you can do 2 quadrants, and between each quadrant there's a 10 seconds gap, and you can do 2 or 3 quadrants as you choose over 180 degrees hemisphere on both sides basically.
Okay, that's very interesting. Because probably I guess the micropulse and the lasers are more popular because they are driven by the company that drives the laser. So if you have a US-based company or a European company selling the machine, I think you will find it's all over the world. Whereas the company which doesn't sell the ultrasound so much, you probably won't see it or hear of it much.
Yeah, and horrendous price, I think, of those, those disposable docking cups that are there. Those are actually very expensive, and they are disposable. You really cannot use them. You can't eat, you can't do anything. So that's the reason I think
there are a couple of other companies coming up with the same micropulse. I think there are 2 other companies, ARC and then Quantil and some other companies also. So if they come in with probes which are not timed for 90 minutes, then I guess the cost can come down. We were all using the G probes earlier without the timing and so on. Some other company has decided, for whatever reason, to time it at 90 minutes. So that is definitely a problem.
Yeah, that's the reason I thought that, because you're timing this at 90 minutes, but in the UCP you have the choice of, doing it as you please. And each thing is about 20 seconds with 10 seconds gap, and you can do it in quadrant-wise, 2 or 3 as you wish, basically.
Yeah, I guess there is no scientific reason for keeping it at 90 minutes except for probably a monetary or a financial interest. I don't really see the need to time it at 90 minutes when it can actually work much longer.
Yeah.
In addition to that, I just want to add on one thing. Maybe when you're using a lot of patients, like you want to pull in and do it, this is again an idea from Dr. Murli. He was just saying that you can prioritize the previous day based on how much of percentage of IOP is needed or which needs more importance. So you can prioritize that as a first case, and then subsequently, because there is a claim that it may not work as effectively as the first cases comparative to the other fifth or sixth case. So maybe I would also agree with Dr. Murli that, like, he was suggesting us that
How we prioritize cataracts in younger patients in the one-eyed
so you
one
can,
first.
yeah, the high risk eyes could go first, and then you can less relatively fewer later. Yeah.
Yes. So I think we move on. We can go on and on and on, but in the interest of time, we move on to the debates. So the first debate, are you ready to share your screen? The first debate starts with appositional angle closure with cataract. Needs YAC PI before cataract surgery. Dr. Shagurika Patyal would agree to that, and Dr. Devdas Mukherjee would disagree to that. And we'll have the final take-home message from Dr. Ruchi Goel.
Am I audible? And is my screen?
Yes, you are. Yes, you are.
Yeah. So I've been given this topic, appositional angle closure with cataract, needs YAC PI before cataract surgery, and I have been made to agree with it. And so that's very interesting that a patient actually has a cataract and he also has a PACS, that is appositional angle. Now, is a PI needed at all? Is a PI needed for treatment of PACS or for cataract surgery? Will a PI help the patient who has only appositional angle closure and is also going to now undergo cataract surgery? Will it really help him? Does my patient have comorbidities? Let's say, for example, like uncontrolled diabetes, cardiac ailments, or uncontrolled hypertension, all of which probably need control before the patient is being taken up for cataract surgery? That is a very important point because we have patients who are geriatrics. Is it also very easy to operate on eyes which have got shallow anterior chambers? All of us are doing it. We all know the problems. How much endothelial cell loss will occur when we operate on cataracts with, let's say, shallow ACs? Also, will there be AC deepening by a PI? Will that also help my cataract surgery? So let's go on to a little bit of anatomy, and that is the depth of the anterior chamber of any eye varies between 1.5 to 4 millimeter, averaging 3 millimeters, tends to become shallower at old age and eyes with hypermetropia. And as the of angle closure of increases. So in primary angle closure, as we know, primary angle closure suspect is a person who has 180 degrees of iridotrabecular contact. Person has absolutely normal intraocular pressures and with no optic nerve damage. In other words, this person has appositional angle closure, which my patient has now. Others I'm not going to go into. And also know that this is a reversible, non-permanent iridocorneal contact. And we also know that suppose, for example, the AAC or the appositional angle closure persists after an LPI, they are more likely to develop pus. And this actually lead to angle closure. With keeping these facts in mind and also with the fact in mind that yes, in this appositional angle closure, the recommended treatment is, should we do an LPI or should we just go in for observation? So at present, we know that there are no completed clinical trials have documented the benefit of an atherectomy for PACS, and yet the relative safety of the procedure, because it's safe, it is hardly takes any time, it's not as expensive, let's say, as a cataract surgery, has allowed its wider use in the hope of preventing an acute angle closure attack or, let's say, a glaucoma. And also we know that observational studies have suggested that majority of patients with PACS will either not develop PAC or a PACG, and this has also been documented in our own country by Vijaya et al. And therefore, although LPI is recommended as the initial treatment of choice in an angle closure disease, it is not mandatory to perform an LPI in all primary angle closure suspects. So first, let me understand that shall my anterior chamber actual angle deepen if I do a PI? So there was this elegant paper which has been done, which has been published by Greaves Arch at Clinical Ophthalmology, in which they have found, they evaluated the association between the ocular, they checked back whether there's any widening of the anterior chamber angle by laser peripheral iridotomy in primary PACS patients using the FT-ACE OCT. And this was done in 66 eyes. And what they found was that the angle opening distance, recess area, the trabecular iris surface area increased by 48 to 73%. And this was, of course, this is very heartening. So we know that if we do a PI, our anterior chamber angle definitely deepens. Along with that, does it also affect our anterior chamber depth? So now this was done in PACS. Yes, we're talking about PACIs. In this paper done by K. Lai et al., in which they were checking about the morphological changes of anterior segment after LPI in primary angle closure, they found that LPI leads not only to an increase in the peripheral anterior chamber depth and anterior chamber volume. So we have two wonderful additions that come to us, but also an increase in the central anterior chamber depth in eyes with primary angle closure. Therefore, if we perhaps do it in a PACS, obviously we're going to get these advantages. So how much angle does a PI open? And this again was by Kansara et al., where they found by using the ACE OCT, they found that there was a significant increase in all parameters after LPI, excepting perhaps the superior angle, which in other papers has also been found that this one deepens the least, probably the effect of gravity. Now we have to consider, therefore, we realize that a chamber will definitely deepen if I do a PI, and it's going to help me in my cataract surgery. But what are the other features of a primary angle closure eye, let's say eye having a PACS? Now all these eyes have an average axial length approximately 1 millimeter shorter than normal eyes. They have other anatomical features, as my patient has an occludable angle. They have short eyes, they have a shallow anterior chamber depth, they have thicker lenses, and there's a closer relationship between the lens and the posterior iris surface. All these features, as glaucoma specialists, we all know we are heading towards one probable effect, complication which may occur and which we don't want to occur, and that is probably malignant glaucoma. So suppose I do a PI, at least my diagnosis maybe after surgery, maybe help that yes, I have an adequate PI, then possibly then I can say that this patient may be going in for a malignant glaucoma in case he so does develop these symptoms. Now, Uday Devgan says that shallow anterior chamber is a challenge during cataract surgery because we find that he's got already working in the tight confines of an anterior segment of the eye. Now, the volume of the working space is just about a fraction of a cubic centimeter, less than 1 centimeter square, with very delicate ocular structures just millimeters away. And what are those structures? They've got corneal endothelium, posterior lens capsule, and they are subject to irreparable damage should the fluidic balance destabilize the anterior chamber. Of course, we have got various techniques which we can utilize to deepen the chamber during cataract surgery to provide a wider margin of safety and help us get good outcomes. And even performing a capsular excess at the beginning of cataract surgery is very difficult due to poor maneuverability and lack of flattening of the anterior lens capsule. So I'm not going to go into methods, but we all know that give cohesive viscoelastics, then do a limited pars plana vitrectomy. But if we do a limited pars plana vitrectomy in order to increase anterior chamber depth, then we may be also causing problems, additional risks to the retina, and of course raising the bottle height. So we have methods by which we can increase the chamber. Now, we have also found there has been a very nice paper in 2015 published by Wang et al., where they have done a prospective study on 135 eyes with cataracts, where they divided all the anterior chambers with the gradation of cataract into 3 groups. And grade 1 was where they had 1.5 to less than 2.5 centimeters and so on of the anterior chamber depth. What they found was that endothelial cell loss was significantly higher in those people who had an anterior chamber depth of grade 1 than those who had in grade 3 in grades of 3 and 4 cataract density. even 2 months after phacoemulsification. So if we are doing a cataract surgery in a shallow chamber, we know that we are endangering the endothelium also, which is so important for our visual outcome. Therefore, if I do a PI, and in other words, increasing my anterior chamber depth, increasing the volume, increasing the depth not only centrally and peripherally, and the angle, plus I'm also preventing endothelial cell loss. Now, we have so many patients who have got so many comorbidities. Sometimes their control of just simple diabetic status requires a few months. Shall we wait for that time for the iridocorneal contact to keep on occurring as to occur and therefore land us up into further problems? Rather, just do a PI which hardly takes a few seconds, and then after that, go ahead and do comfortable surgery and allow the patient's comorbidities to be controlled very well. With this will definitely help the patient. So, in other words, I agree that perhaps the YAG PI is worth the effort, even though the patient will be undergoing cataract surgery straight after. I rest my case and thank you for your patient hearing.
Thank you very much, Dr. Sagarika Patyal. That was indeed well said. We move on to Dr. Mukherjee for his disagreement to the motion this evening.
I don't know what happened. It was
sharing the screen.
Yeah, I don't know why it's not going.
Surjit. Surjit, you have the slides.
I have the slides.
No, he has not sent the slide.
I can see everything, but why it is not going?
Did you
yeah.
do this sharing? You have to first share the screen and then open your presentation.
Am I still in the meeting or not?
Yes.
Yeah, you're in the meeting, but you have to first share your screen and then open your presentation.
But I can't see the opening.
You go back to, just the PPT, don't put it on slideshow. Just put it as if you just opened your file, don't put it on slideshow. And then you can, put on the Zoom full screen there, you share the screen and then you go back to slideshow.
Is okay now?
Yes.
Yes. Yeah, it is coming. Yeah, it has come.
Okay. Thank you. Initial hiccup. Thanks for the invitation for joining the very accomplished glaucoma surgeons. Debate is for the sake of synthesis of the best possible outcome for our patients. It is not a quarrel. No one wins and no other loses. We might have disagreement in opinion, but we do not have any conflict in patient's interest. In a discussion of medical legal aspects of glaucoma management, Dr. N. KAO and Professor G.N. Shenoy expressed that glaucoma could be managed or treated in more than one way. This could cause genuine differences of opinion, and one glaucoma specialist clearly should not be held negligent merely because his conclusion differ from the other professionals. I'm just quickly going through the basics of primary angle closures. We all know primary angle closure suspect. If we are in the routine clinic, if you miss the Van Herrick's and the peripheral depth, you miss it. And if the patient lands with an acute attack, you will pick up and probably you will rectify your error. When it moves to PSC, again, if you do the routine tonometry, probably you will get another chance to rectify yourself. Again, once again, if the patient comes with a acute attack or high intraocular pressure. And of course, primary angle closure glaucoma which is a disaster, and we should not want them to happen at all. Now, other thing, possible mechanism. There are elaborate mechanisms of development of primary angle closure. I'm making it very simple. Relative pupillary block. What happens actually, posterior chamber fluid accumulates and the pressure in the posterior chamber is not enough to lift the iris from the iridolenticular adhesion or apposition to come to the anterior chamber, and the fluid in the posterior chamber increases, bulges the peripheral thin iris, causing gradual closure of the angle with appositional closure, and if you leave it, it will be a sanicular closure. And the second most important element is the growing lens volume with ages. It never shrinks and always lens volume increases, whether it is a small crowded eye or a large myopic eye. It grows whole of his life. Now, with these two consideration, if the is LPI panacea for angle closure glaucoma, I think there is some confusion. Is LPI is the first aid for angle closure glaucoma management or is the treatment? If it is first aid, I have no objection. But if it is the only treatment, definitely I have got second view. If it is the panacea for the initial treatment, why need additional medications? Why after LPI, posterior trabecular meshwork does not open 360 degree? Why further interventions, again another LPI, lens extraction or glaucoma procedures required? Do that all mean simple stabilization of IOP between the posterior and anterior chamber is not enough? There is something missing, rather ignored factor. That is the aging lens, probably is the real culprit. Now we consider the risk factors. Shorter hyperopic eye, we don't have any control to do it better or manipulate it. Thicker cornea, again we are helpless. Thick iris, failure to shed water during dilatation, probably that is secondary to ciliary body or choroidal inflammation. If we can treat the root cause, probably that will be better. But lens sickness, which is ever growing after birth till death, lens position probably is going forward because the posterior segment is crowded. Lens have got little volume to go posteriorly, so there is only way to come forward and push the iris forward and causing appositional and sanical closure. And definitely this waxing waning causes juvenile laxity. So these are the risk factors. Out of these three, only last three lens related things we can manipulate, other we are helpless. Now come to the cataract. Lens is already dysfunctional. It is cataractus. Cataract is not a single entity, switch on, switch off disease condition. It grows after the birth, lens opacity happens, it is universal, it grows and grows and more, and at some stage, it is not useful. Usefulness of a lens comes according to the profession and requirement of the patient. We, the doctor, cannot decide whether the lens is really problematic. But we know with aging, lens is already dysfunctional. Presbyopia sets in because it is losing its plasticity. Some amount of cortical cataract is expected, and it will advance even after LPI. Hardening of nucleus started, adding more volume discrepancies. Zone will become lax, and with acute attack, glaucoma flecans develops. So if you remove the cataract, na rahega baas, na bajega basuri. So why lens extraction? Large population of patients with angle closure treated with LPI went on for the requirement of lens extraction. It is not what I am saying, it is in the literature. Success of LPI depends on timing of presentation, when you are getting the patients. In our rural setup, we never expect to get the patient within 1 week. I have worked in UK, I have seen there are many elderly patients who presented in the emergency having bilateral attacks over 1 month. Now consider the socio-economic consideration. What is that? Direct medical cost to visit a doctor, eye care provider, ancillary testing, medical and surgical intervention. This is equal if we do LPI or if we don't do LPI. But what is the direct non-medical cost? Transportation. Indirect cost, loss of productivity of the patient and caregivers. This is not from me. This is a preferred practice pattern of an American academy. Now, if we do only a single LPI, leave the patient, we are not treating, we are not doing anything out of these three. So it will be repeated expenditure. The patient will come for the follow-up, and one day they have to do the cataract. And recurrence of acute angle closure glaucoma after lens extraction is rarely heard of. So now you consider the result of lens extraction. We know that LPI does depend the anterior chamber parameters, but that is for a while. That is not for a permanent period because lens continues to grow. Gonioscopically, the lens extraction group achieved a larger postoperative angle width than LPI. Posterior trabecular meshwork visible with static gonioscopy after operation. All anterior segment perimeters, AOD, TIA, and TISA were significantly greater after lens extraction than LPI. Iris curve decreased after lens extraction, and the iris was flatter than lens extraction after lens extraction than LPI. And definitely, and that is most important, improves the visual acuity of the patient and increases his confidence. So, but in my opinion, patient is has the final say. But when you are proffering our treatment to the patient, we must tell him, if he doesn't agree or she doesn't agree for the lens extraction, we must tell him, you need a regular follow-up that is a prolonged, maybe lifelong. Regular medication, if prescribed, must be compliant. Patient must be warned that the vision may deteriorate due to acute attack itself, increasing age, and sometimes LPI also causes lens opacities. And if we go for the lens extraction, we'll explain to them today or tomorrow, it will be required earlier than probably normalized. Finite short follow-ups, requirement of lifelong medications is much less. So they will decide. We cannot push them, or we cannot say them, this is my technique, you go for it, and hiding the other way. Because again, we might have disagreement in opinion, but do not have any conflict in patient interest. Thank you.
Thank you, sir. Thank you very much for that superb talk. And with that, we move on to Dr. Ruchi Goel for the take-home message.
Yeah. Can you stop sharing the screen, Dr. Devda? Yeah. Yeah, thanks Dr. Chandrima and KAO for inviting me to this glaucoma symposium. Actually, I'm not a glaucoma specialist, but then yes, I think we're all dealing with these kind of patients. And I would like to kind of, divide this situation into two set of patients. There would be immature cataracts that would be requiring surgery, and those cataracts which can be observed for some time. And then there would be a situation where the patient has some kind of comorbidities where immediate surgery may not be possible. And another situation like in COVID times where patient may not be willing to get operated at least for another month or so. So if I take it that way, there is a patient where the surgery can be deferred and there is an oppositional closure, then I think it will be better to go ahead and do a PI. If there is a patient where you need to, operate within the couple of days, and in those cases, doing a PI may not be required. But then again, I am putting a question mark. This is not a hard and fast rule. And sometimes, what happens is the cataract may be so dense that you're not able to assess the fundus and you're not comfortable as to what kind of prognosis you're going to give the patient. So if you do a PI, you are quite comfortable right from the beginning that you have assessed your patient properly. And even in the OT, you're not scared that while dilating the patient may go into an attack. So you're otherwise quite comfortable throughout the surgery as well as the post-op care. But if you have to do a PI, the problem is that you need to wait for another couple of days for the reaction to settle down. So you just can't go ahead and, give a shot on the iris and start operating. So that is a little on the disadvantage side when you're doing a PI there and then. Then when you go to the surgical part of it, if you have decided to operate such kind of patients where there is an oppositional closure, and you either whether you do a phacoemulsification or SICS, either of the situations
the endothelial cell loss is bound to be more. So in spite of all the efforts like deep, raising the bottle height and using a lot of high molecular weight elastics, if you have even if marginally you're able to deepen the chamber, you're surgically far more comfortable when you are doing the surgery. So definitely, as Dr. Devdas was saying, that clear lens extraction, the lens extraction is going to deepen the chamber. And of course, it's no match to doing just a PI. I agree with you. But then, it's not just the lens. The results of lens extraction are going to come later. So, but your surgical part is going to come before that. So doing a PI at that time may be of some help to all these procedures. And also there may be a situation where many of these patients are associated with high hypermetropia, and there is a lot of overcrowding of structures. So if you have that kind of a situation and on top of it there is a shallow chamber, I think the post-operative results may be a little better if you have, if whatever bit of comfort you can achieve if you have a small PI beforehand may help you. So I think one has to really take a decision varying from patient to patient. Definitely in this COVID era, you have to choose your patients. As I said, if you have to defer the surgery, if and there is an opposition, you must do a PI and follow up after some time. However, there is, the number of visits are going to increase if you want to do the surgery immediately. So one has to really weigh the pros and cons of the situation and then decide accordingly. Thank you so much.
Thank you. Those were great inputs and very straightforward message. With that, we'll move on to the second debate of this evening, Dr. Shirish and Dr. Vineet Ratra. So NVG has a better outcome now with judicious use of anti-VEGF injections.
Yeah, hi, good evening all. I thank Dr. Chandrima and Dr. Surajit especially and the whole team of KAO for having made this possible. Let me start sharing my screen. Do you see my screen now?
Yes, yes.
Okay. So the topic that I'm going to talk is that initially the outcome is better with judicious use of anti-VEGF injections. In order to build my case, let me take you through a step-by-step approach. First, I want to ask, or rather say, are there any alternatives available about what we are discussing? Second, are the anti-VEGF effective? And third thing is, what is the side effect profile of the anti-VEGF and are they justified actually? And finally, I'm going to address the main question, does NVG have a better outcome? So now to start with, there is no doubt that PRP is definitely the gold standard. Here the thing is, we are not emperors as when it comes to treatment of neovascular glaucoma. We have very, very few choices. We are rather, I would say, beggars when it comes to treatment of this. The choice is only PRP or anti-VEGF and then the lasers and the surgery. So among these small choice that we have, the gold standard continues to be PRP. But however, we cannot do PRP when the media is pretty hazy, especially like vitreous hemorrhage, cataract, and corneal edema, which is pretty common when the IOP goes high. It can be either due to low endothelial count or high IOP. Both of them can cause a significant edema, and which are extremely common in patients who are diabetics as well. PRP results, moreover, are very slow. Once we do PRP, the effect for the complete effect for it to be seen is almost something like 1 month for us to see the effect. So this is like abnormally slow, and by then a lot of things, changes can happen in the eye. We can lose the optic nerve very, very easily. PRP alone may not be sufficient in halting, especially the fibrovascular membranes many times. So you can achieve a resolution of the blood vessels, neovascularization and all that, but the fibrovascular membranes continue to stay. Given this background, so these are the drawbacks what we have. So choices for us remain extremely few. So then we come to the anti-VEGF. The anti-VEGF, the VEGF inhibitors can stifle the neovascularization process secondary to retinal ischemia, and they give better visual prognosis as well as reduce the IOP by itself. So the evidence is very, very clear for us to see. You can see such a florid neovascularization pattern on gonioscopy. So once you give the anti-VEGF injections, there is regression of neovascularization not only on the surface of the iris that you see here, but also in the angle processes and areas where there is extensive neovascularization here, which ends up creating a lot of difficulty for us. And this is what actually gives us more cases of neovascular glaucoma, this fibrovascular membrane angles. So see the anti-VEGF as something like this. So this is a war zone, what you have, and this is a patient who is being hit by a bullet, and this is the doctor in the war zone who is trying to attend to this this patient, you can see, or the soldier who is a patient now. So in this scenario, if the patient has to be retrieved in the war zone, you need covering fire here. So the covering fire is being given here by the helicopter and other soldiers, and then safely this patient can be taken out of the war zone and then he can be attended to. So the role of anti-VEGF is something very, very similar. So it gives you as a protective agent for what you need to do later. So this is the case of very severe guy post bevacizumab, 1 week post-op. You can see how clear not only the cornea becomes, but also see how quiet the iris is and how shiny the eye becomes. So this is a iris angiography 3 weeks post-op. You can see there is hardly any leak happening. And then such cases, you can go ahead and then put a shunt in them, and then the eye becomes extremely quiet and nice. So another case here, this is again edematous cornea with extensive fluoride NVI here. And this patient, you can see that the cornea clears up, and then there is a complete involution. You can even see the ghost vessels in these areas, which prove that the neovascularization has indeed settled. So we don't have any shortage of evidence here to prove these things. Again, it is a similar situation. Even a magnified view, you can see a fluoride NVI like this becomes so sparse and then so clear, the iris almost becomes as it was before. This is a blown up picture. You can see even the smallest of the vessels also go in for resolution. Though the shrinkage of the iris may not completely resolve, but you can see that it does a lot of work in terms of resolution of the new vessels. So you get a head start with the use of anti-VEGF. Very rapid action in resolution of neovascularization of the iris. Partial reduction of the intraocular pressure as well. There are studies proving it. And as a result of reduction of pressure, you can have reduced corneal edema. And of course, there is, because the vessels shrink, the inflammation also goes down along with that. And because the vessels shrink, there is reduced risk of intraocular bleeding during the surgery. So this provides a crucial chance to do secondary procedure more safely. Now, are there comparative studies? I am coming to that. Yes, there are comparative studies. I'm going into 2 comparative studies, one for mitomycin trab and another for AGV. So you have studies which says IVB, intravitreal bevacizumab, achieves significantly better surgical success rates, as well as significantly less post-op hyphema, less severe post-op hyphema as well, and no change in complications like endophthalmitis, phthisis bulbi, or marked decrease in visual acuity compared to the controls. Mind you, whatever studies I'm quoting are all very huge studies, big and well-established studies. So studies of another study which says that long-term benefit of IVB may not be there, which says that, you know, even if you give IVB, there is no long-term benefits. It is all short-term benefits. However, even during this short-term, there is this is quite a large part of it is attributed due to the reduced hyphema that we see, and this also turns up in terms of better IOP control. So reduced hyphema is a very, very significant factor, because hyphema is supposed to be one of the major factors which drives the secondary surgeries, glaucoma surgeries, for failure. So as far as AGV is concerned, there are, again, I'm quoting 2 meta-analysis for you here. There is AGV implantation has better success rates with anti-VEGF pre-op, better IOP control again, even with AGV, post bevacizumab, and further reduction in anti-glaucoma medications compared to non-anti-VEGF group, and most significantly, again, I'm repeating the same thing, even in this study and meta-analysis, lesser hyphema, thereby improving the outcome. Both of this are systemic literature reviews, what I have. And another one which I'm talking to you about, what are the adverse events that we may have to face? Actually, the adverse events that we face are not very, very huge. Though this is a huge study of 4,300 patients, mind you, these adverse events, whatever are told here, are not exclusively due to the intravitreal injections. For example, this showed that there were some cases of CVA and myocardial infarction. This made a big news some time back. Myocardial infarction, I'll come to that in my next slide. Aneurysms and toe amputations, obviously these are unrelated, but ocular complications like bacterial endophthalmitis, tractional detachment, uveitis, and vitreous hemorrhage, they were not very, very common. You can see in 4,000 odd patients, you hardly had mind you, these are high-risk patients who had a very low risk of these things happening. So IVAN study showed, I'm coming to talk about the myocardial infarction. There were quite a few studies, especially 3 studies which were very big. The IVAN study, GFAL study, and the MANTA study, all of them said that there is no risk of myocardial infarction. It was the IVAN study which told initially that there was an increased risk of stroke, but in the second year of the same study, they said that this is not true. When can we give the anti-VEGF? We can, there are specific situations where we should attempt it. So especially when the media is hazy, then when you want to buy time, you can try giving bevacizumab. Suppose you want to buy time for whatever reason. It can be a patient who cannot tolerate the surgery for whatever reason, uncontrolled diabetes or whatever it is. Up to 9 months, you can have a window period where you can keep on trying the anti-VEGF injections. In presence of NVA and elevated IOP, but no evidence of angle closure in presence of NVA or NVA where IOP is high with corneal edema, and in presence of again NVA where you need regression of vessels before the surgery. So again, poor retina visibility to do PRP, we can go ahead. And again, when inflammation is a major factor of concern for you, even then you can take a call of giving anti-VEGF. When time is short, you can't wait for PRP, this being one of the commonest situations where IOP is uncontrollably high and you need to act very, very fast. So drawbacks of the anti-VEGF is main thing is it works for a very, very short while. That is the biggest drawback that we face. So the RAVE trial talked about this. Now they wanted to try and see, is it possible to avoid PRP completely doing an anti-VEGF, and is it possible to maintain stable visual acuity? They tried to do that. Then they concluded that no need for PRP only as long as anti-VEGF is on. That means you can avoid PRP only as long as you are giving anti-VEGF. Once you stop the anti-VEGF, ultimately you have to depend upon PRP to do a long-term job. However, they can also concluded that visual acuity was not only preserved but improved as well. So in summary, what I would say is there are both positives and negatives here. So the comprehensive approach is the key to managing neovascular glaucoma. It's not just one approach alone. Aim is to control NVA and IOP preservation and prevent revascularization. Thoughtful use of PRP, anti-VEGF and surgery is what we need to do. And anti-VEGF is an effective temporizing treatment. This is what I would stress upon, and provides a crucial therapeutic window for the surgery. So I would leave you with this dramatic image where you can be easily convinced of how wonderful a revolutionary thing we have ended up in the anti-VEGF technology that we have, or the drug which has come in. You can see so much of a leaking blood vessel, the eye becoming so quiet, and as if it is being given to you on a platter, kept ready for you to do the secondary surgery that is required. Thank you so much.
Thank you very much, Dr. Shirish. That was a great talk, very informative and great pictures. We'll move on to Dr. Vineet Ratra. We'll move on to Dr. Vineet Ratra.
Thank you, Shirish. You made my work quite easy. And thank you, Dr. Chandrima and the Kolkata Academy of Ophthalmology for having invited me over here. Well, I'm going to tell you what the limitations of using an anti-VEGF are. Dr. Shirish has told you that there are limitations, and he's made my job much easier with that. Well, we do know that the pathophysiology and stages of neovascular glaucoma do include these, where you have normal IOPs with a rubeotic and a pre-rubeotic stage, and then when you have higher pressures with open angle and angle closures glaucoma. Well, the usage of anti-VEGF urgent helps in the first two, not so much when the pressures are high and you have such florid NVI and NVA in the angle where it will not help much. The management options then become treating the pressures and then treating the ischemia. Well, the most definitive method of treating the ischemia is laser photocoagulation. And this, or KAO to the periphery if your view is not good enough, is going to help reduce the release of these VEGF factors. Giving anti-VEGF helps treat the effect, but that's temporarily. You need multiple injections. And while giving injections in these eyes with an obscured view, corneal edema, cataract, which is hemorrhage, is not an easy task. We also do have gaps in understanding as to which drug should be given first, how long can we say, that 9 months is an arbitrary number, and to choose if one doesn't work, which is the second line of drug that we could give. There are various ocular complications that could occur with giving anti-VEGFs, which I'll just discuss a few of them now. The first is the endophthalmitis, which all of us dread. In this study in the US, they found that old age, and those are the risk factors where patients do have NVG, patients with comorbidities, and patients having multiple injections are at a higher risk of endophthalmitis. Patients who get anti-VEGF also are at a risk of hemorrhage. There has been a report by Brosses et al. Where they showed that they had a choroidal detachment, a hemorrhagic choroidal detachment, with a subsequent sympathetic ophthalmia in the other eye. There are also reports to suggest that just giving anti-VEGF injections could lead to large subretinal hemorrhages, both of which could cause a decrease in your vision. Anti-VEGFs are also known to cause ischemia, where the studies have shown that there is a significant reduction in the retrobulbar flow parameters in AMD patients, and also retinal arterial vasoconstrictions in patients who have been given intravitreal anti-VEGFs. There have been reports suggesting non-arthritic ischemic neuropathy, vascular occlusions leading to infarctions, and also reports suggesting ocular ischemic syndrome occurring in these patients. Well, are we treating pressures or are we raising them? We do know anti-VEGFs can raise intraocular pressures. Short term is because of your volume overload, and even long term, as has been seen in different studies for ARMD, that it does rise in up to nearly 25 to 30% to up to greater than 6 millimeters of mercury. Well, more than injections, the lesser the outflow facility. This does cause sustained intraocular pressure rises. This is because each IOP spike can damage your trabecular meshwork. Another risk factor is in patients with pre-existing glaucoma, you could get sustained intraocular pressure rise. Why this occurs is because of a microparticle obstruction of the trabecular meshwork by the anti-VEGF, by the silicon microdroplets, and by the protein aggregates. Also, anti-VEGFs have a direct effect on whatever of the little bit of open angle that you have, but it slows the metabolism and replication of the trabecular meshwork cells. Anti-VEGFs also cause a trabeculitis, which can again raise intraocular pressures, and also acts on the Schlemm's canal, where it reduces the endothelial cell permeability and smooth muscle contractility, all of which causes sustained IOP rise. We do know neovascular glaucoma is a systemic disease. By systemic disease, it occurs in patients who are diabetics, who have diabetic retinopathy. That means they have nephropathy, they have neuropathy, or in patients who have CRVO. And CRVO is generally associated in patients with hypertension, atherosclerosis, or a hypercoagulable state, or patients who have vasculitis or ocular ischemic syndrome. All of these are morbid conditions, and using an anti-VEGF can exacerbate these systemic complications and could also even lead to death. So, well, the next question you would ask is, what harm can such a small intravitreal dose of anti-VEGFs do? Well, the half maximum inhibitory concentration of these anti-VEGFs range from 7 to 30 days in any of these anti-VEGFs, and these exposure levels are sufficient to suppress the circulating VEGF in vivo. Well, what does this do? This can cause the patient to have cardiovascular risk factors by causing left ventricular dilatation and contractile dysfunction. It also reduces vascular permeability, raises systemic blood pressure, and also helps promote the development of thromboembolic events. Low VEGF levels in blood are poor prognostic indicators for major adverse cardiovascular and cerebrovascular events. Giving anti-VEGFs with this maximum inhibitory concentration being high can exacerbate these conditions. This has been shown in different non-industry driven reviews on systemic contraindications, where you could get thromboembolic events and even cardiovascular incidents leading to death. So do the risks actually outweigh the benefits? Well, most people do use anti-VEGFs to treat in the armamentarium for treating neovascular glaucoma. But what visual prognosis do these patients have? These patients generally end up with maximum of counting fingers vision. And in eyes with such visual prognosis, is this even worth it? If you're just wanting to treat the intraocular pressures, why don't we just do a cyclodestructive procedure instead? Especially when the cost factor involved with a cyclodestructive procedure is much lesser. We do know that the prognosis of neovascular glaucoma is very guarded. This is both due to the retinal ischemia and due to the nerve damage because of raised intraocular pressure. And if these patients are symptomatic, a cycloplegic and a steroid, they are good enough. The patients are very happy with the pain relief of these. In vasculopathy, prevention is the primary goal. We could give anti-VEGF, we could have a successful surgery, but are we going to end up with any visual improvement? The surgery was successful, but the eye is blind. Thank you.
Thank you very much, Dr. Atra. That was a wonderful talk. And we have Dr. Mehta for the take-home message.
Yeah, thank you, Dr. Chandrima. It was an excellent presentation by Dr. Sirish and Dr. Vinit. My video is not working, I think. Yeah, it's unmuted, but it's not working, I think.
Oh, it's still not working? Okay.
Yeah, I think so. Some problem with this thing. The thing is that it was an excellent presentation for and against. The most important thing I would like to highlight is when a patient of NVG comes, it usually has a florid presentation. In our clinic, fortunately, we have a standard protocol for all diabetic patients. So whenever the pressure starts going up, we look for NVG, if there is any NV iris or NV angle, because sometimes even NV angles can be seen before NVI develops. So that is the indicator when you have to intervene. So the most important thing is watch on pressure. Why I insisted on this is like there are like two categories. The first patients which come to us with a early presentation or where the angle is not close with a fibrovascular membrane, you can definitely try in this thing anti-VEGFs, and the angle responds very well. So whatever the angle is open, it starts functioning, and you can salvage the eye very early. Of course, you have to find out what is the root cause and treat the root cause. The next is where there is already fibrovascular membrane or NVI, florid NVI, and the angle is zippered up. So there, the role of anti-VEGF is totally different. There, you need to do PRP, you need to do something for this eye, and you want to reduce the pressure. So in these patients, giving anti-VEGFs, definitely it clears the cornea, the pressure goes down, the clears the cornea, clears the NVI also, and in fact, I have noticed that there are some studies also, the pain and inflammation goes down dramatically. So the patient feels very happy. So the next thing is that you have to ask the patient to undergo PRP. So that is the next thing to tide between the time when the PRP takes over. So in that time, you have to watch the pressure for any rise in intraocular pressure, because if you're going to do surgery, then giving anti-VEGFs 3 to 5 days before your surgery, and then doing a AGV or a trabeculectomy if you want with some MMC or this thing. I prefer AGVs in these patients, so that would give the best results in these patients. Thing is that if you are going to do surgery, definitely you don't want any intraoperative bleeding or postoperative hyphema also. So there it works well. Obviously, if you are going to do PRP after you do surgery, then there are chances that it would be delayed further. So my thing is that give a intravitreal or intracameral anti-VEGFs, and then do a PRP, treat the root cause, and then again get the patient for surgery after that. So that would work well. So you have to use these things judiciously. The only question against not using is that if the patient has ocular ischemia, obviously it's going to exacerbate. If the patient has fluid fibrovascular membranes on the retina, they might contract, and there are certain reports even the membranes in the angle contracting and the pressure going up very high. So these things you have to keep into mind, and obviously these patients need close monitoring even after PRP, even after surgery. So definitely few years back, a decade back, there were no anti-VEGFs, and we used to see these patients going totally blind after developing NVG. But the use of intravitreal or intracameral anti-VEGF and treating the root cause and doing an immediate surgery has helped these patients very well. Obviously, there are some systemic contraindications, but the thing is that in our routine practice, we hardly see them. And very rarely we have heard that, okay, this patient was given anti-VEGFs and he developed some thromboembolic problem, but that is very, very, very rare in our clinical scenario. So that's my take-home message, that use anti-VEGFs very judiciously, especially just before surgery and especially before treating the root cause. Definitely patients are happier and the cornea clears very well and they respond very well to whatever treatment, whatever surgery he's going to undergo. Thank you very much.
Thank you very much. Very straightforward take-home message. On this note, I'd like to bring in Dr. Dipanjan Paul. He's the person who coined this debate. So what would be your take-home message, Dipanjan?
First of all, I would like to say that I didn't realize that these all debates, the presentations are absolutely fabulous and fantastic. Specifically, Dr. Shirish and Dr. Vineet, like this is really, really mesmerizing ways of this presenting the thing. I will definitely go as whatever Dr. Medha said, and definitely anti-VEGF has a rule, and it gives so wow factor the moment these patients come with corneal edema, quite a bit of pain, and if the anti-VEGF can be given then and there, and specifically when the NBI is just new and just started, and it gives definitely good results and gives you sufficient window for for your any further management, whether it's a trabeculectomy or it's a planned GDD, and that is my take. And I also would like to thank Dr. Shirish, particularly that coining that term, that is whatever the term was. Dr. Shirish, please unmute yourself.
Temporizing?
Yes, temporizing and therapeutic window. That is fantastic. That is fantastic.
Yeah, temporizing.
I just want to highlight, if you really want to postpone the surgery because you are doing PRP or patient is waiting for his fitness and other things, you need to repeat the injections at 4th week, at 8th week.
Yes.
And maybe one more after 8th week. So that is the maximum limit.
Yes, yes, that is the problem with anti-VEGFs, because we all know that the anti-VEGF action is limited to a time, and yes. Dr. Shirish has definitely told us that ultimately it is temporizing the things, and ultimately the major thing is doing a PRP and creating a hypoxia so that the new vessels do not grow.
It is more like the first few images I showed you about that war zone where there is that covering flare. Exactly. I think anti-VEGF is something like that. You know, it gives us.
Just tied over, yes.
Yeah, we never used to have so much confidence in doing a TRAB or a AGV before the anti-VEGFs came in the newest glaucoma. I wouldn't have the guts to do it.
Yes,
I would always be
then the next day you will have a 8-ball hyphema or something like that.
Yeah, yeah. Thank you very much. So, and Dr. Medha, we couldn't see you, so we look forward to your presence in the next KO webinar where we
Sure. I will solve this problem, whatever has happened with my laptop
wonderful.
video.
But don't worry, you would be coming now and again at the KO webinars, so we will see you the next time, definitely.
Thank you. Thanks a lot.
Thanks. So with that, we move on to the next topic. So the next topic has been slightly changed. So that's, it reads, post-keratoplastic glaucoma can be treated medically. And for medically treating it, we have Dr. Sharmila. And for not medically treating it, surgical treatment, we have Dr. Sujata.
Good evening. Thank you, Chandrima Madam and KAO for the opportunity. I hope my slides are visible and I'm audible.
Yes, yes, clearly.
Okay. I do not have any financial interests, and I also want to say that the illustrations or images used here are just for fun and not to hurt anyone. So let me just proceed. So treating post-PK glaucoma with surgery is like a Shah Rukh Khan movie where the outcomes are really unpredictable. There will be a hit and there will be several misses, and again there will be a hit sometime even after 5 years or so. So how about medical treatment? So treating PK glaucoma with medicine is always consistent, though we have a very old hero, Rajinikanth, his every movie is a hit. So something like that, I would say that medical management is a consistent way of treating post-PK glaucoma. So with that note, so let us go into what is post-PK glaucoma. It's the second leading cause of graft failure after graft rejection. The incidence of post-PK glaucoma ranges from 9 to 35%. It's often difficult to diagnose and challenging to treat. The first line of treatment is always medical, and with the recent advances like ROCK inhibitors, there has been a promising role in eyes with poor endothelial function as well. So there are several risk factors for post-PK glaucoma, most importantly in eyes with pre-existing glaucoma, presence of PAS, regrafts, history of trauma when you do a combined surgery, and in old age. And the incidence of post-PK glaucoma differs according to the indication for the primary surgery, and it's most importantly seen to be higher in eyes with pseudophakic bullous keratopathy, aphakic bullous keratopathy, and those which are undergoing a regraft. So if we look into the pathophysiology, there are several mechanisms which has been established. The most important ones are the open angle glaucoma. Most commonly, it is the trabecular collapse. And there are less frequent or the less common ones like the angle closure glaucoma or the PAS, which happens even later. So predominantly, the major treatment is based only for open angles, which is basically medical. And when you do the treatment for angle closure with surgery as well, they may need medications even after doing surgery. So ultimately, medication is definitely a mainstay of treatment in post-PK glaucoma. So when you look into the medical management, it is the first line therapy. It is definitely very safe. It is cost effective. It is independent of several patient factors, like you don't depend upon the age of the patient. You don't depend upon the conjunctival cytology to see if it is going to work or not. So intraocular pressure reduction is going to be ranging between 20 to 35%. And the options available are from beta blockers, prostaglandins, alpha agonists, CAIs, myotics, and more recently, the ROCK inhibitors. So I would say, just like how my opponent has chosen Dr. Rajan, who is actually her first choice and she's constantly happy over the years, medical management is definitely going to make us very happy because it's going to give good outcomes. So when you look at the advantages of medical management, it is basically that you have fixed combinations, so you don't have to use multiple eye drops, and the preservatives. Basically, the complications which are going to be portrayed by Dr. Sujata is basically because of the preservatives, and they have nothing to do with the main drug as such. And we do have preservative-free formulations which are available to address that. And it is a non-invasive thing where it is comfortable, and then it's cost-effective, and there are only fewer complications compared to surgery. So and there are also drugs which are acting on multiple routes, and so you have an additive effect addressing multiple routes and having a larger IV control. So the myth which is usually followed is like CAI inhibitors are definitely contraindicated in eyes with endothelial dysfunction. But what I would say is it can be used with caution in healthy grafts with good endothelial reserve. And the newer add to the medications, there is a Repasudil, which is a ROCK inhibitor. It has several good advantages in addition to giving a good increase in TM outflow. It protects the it gives a neuroprotection. It increases ocular blood flow. It is cornea friendly. It also is very helpful to avoid scar. So there are several reports which have shown that it is good for the cornea and it is very useful in these eyes. And whereas you look at the surgery, it is like a natural disaster, like a tsunami. It basically sweeps away the primary results as well. It basically leads to graft rejections. So do you really want to go for a surgery? Any surgery is not free from complications, and there are multiple complications like graft failures, graft rejections, recurrence of the primary pathology. In addition to that, Dr. Sujata wants to add more complications by introducing a tube, like causing complications like hyphema, causing endophthalmitis, bleb leaks, tube corneal touch. So is trabeclectomy a good choice? Definitely trabeclectomy is not a good choice. Rather, surgery is definitely not a good choice because the results are often unpredictable. The reported results vary, and there is a lot of incidence of graft rejection seen even after the surgery. And multiple complications happen because of mitomycin C as well. If you see, there are a lot of studies which have reported various results with a success of trap as well as a graft failure. And most of these, if you have to see, it has to be interpreted very carefully because the success which they portray is basically the total success. So what is more important for us is we have to look at the complete success, whereas these studies portray the ones which are success with use of medications. And what about the tubes? The tubes in post-PK glaucoma. We use tubes in 40 eyes, around 50% of them are going to fail or just rather need a regraft. So basically because surgery induces a breakdown in the blood aqueous barrier, increasing inflammation and causing graft rejections. So also the site of tube placement. Do we place it in the anterior chamber in phakic eyes because it's very close proximity to the endothelium? It's going to cause a compromise to the corneal endothelium. So we may have to think about placing it in the vitreous cavity, which means a lot of logistics involved, getting a VR assistance, getting a vitrectomy done, so the cost of the tube, the vitrectomy related complications, frequent post-op visits, and most importantly, the need for anti-glaucoma medications has to be also addressed. And these are the various tube success and survivals of the grafts which are reported in the literature. And again, I have to mark, mind you, these are all only the total success. Here they claim that they have a total success of something between 60 to 100%, which is only with the help of medications. And the graft survivals are also very high. Poor graft survivals are shown here. So the complications of tubes are plenty, and needless to say, one is the tube-related complications, and the second thing is the primary problem. That is basically the graft is going to fail because of tube corneal touch, needing a regraft. The percentage of eyes needing a regraft is around 20 to 50%. So look at the patient's perspective. When I discuss the choice of treatment with the help of medicines or surgery, the patient is really very happy and smiling when I say that you need just medical treatment. But whereas when I put a stress on this patient saying that you need a surgery to control the intraocular pressure, he would really be very stressed and anxious because the primary graft may fail. There is a need for regraft, and also there is a huge demand for donor buttons. So imagine getting a suitable button again and having a good acceptance after that. And there is always a need for anti-glaucoma medication after surgery. So this is going to cause a lot of unpredictable situations, worse success rates, and poor visual outcomes. And another thing is, most of our cornea friends are very friendly with us as long as they just feed us patients and we treat them medically. But once we say that the graft has failed and we need a surgery, then they don't even turn back and look at us. So the blame game starts. Then I would blame that it's his fault, he would blame it's my fault, so there's no ownership there saying that we are not responsible. So when you analyze the cost benefit of the medication versus the surgery, you see the cost of medications would be around 350 to 500 for a month, which would averagely cost around 15 rupees per day. But when you look at the surgical cost, the cost of AGV is 35,000, vitrectomy another 10,000, additional medications, frequent post-op visits, and cost of additional surgery and a regraft. This is all going to be a huge burden for the patient. So I would like to conclude by giving certain important points. The main aim of the surgery should be to preserve the graft and to preserve vision. And this is mostly possible only with the medical therapy, individualized treatment options based on clinical findings. Newer advances in medications and fixed formulations have been very promising in controlling intraocular pressure. Timely diagnosis with prompt medical therapy is the key to preserve the visual function and, most importantly, graft clarity. And on the other hand, my opponent is wanting to stacking up surgeries and just by stacking up her bank balance. Thank you. These are my acknowledgements. I would like to acknowledge my colleagues Shiva, Nimrit, Deepa, and Preeti for helping me with the presentation. Thank you for patient hearing.
Thank you, Dr. Sharmila. That was indeed very well debated. And let us hear Dr. Sujata disagreeing with you.
the share?
Yes, please.
You're able to see it?
Yes, yes, yes. You can make it full screen, yeah. Yep, perfect.
I would say I'd like to thank Chandrima for giving me this excellent opportunity, and also KOA for the opportunity given. So I would like to emphasize that I am a corneal as well as a glaucoma surgeon, and I get to see these post-keratoplastic glaucomas on an everyday basis, not like Sharmila, because I know the difficulty. I've seen crystal clear grafts becoming coming down from 618 or 612 vision to no PL just in 3 months. So that's a need. So it's no longer an easy chair treatment of regular glaucomas. So because post-keratoplastic glaucomas can cause irreversible vision loss, though the glaucoma itself can also cause a high incidence of graft failure. And this study, which is dealt with 6,525 eyes, they found that 30% of the patients needed surgical intervention. So what are the diagnostic dilemmas? We know it's very difficult to assess these patients preoperatively and postoperatively, difficult to do intraocular pressure measurements, difficult to do visual fields, to examine the neural structures. The postoperative astigmatism is again going to be a bugbear because it's very difficult to do applanation. The refractive changes can preclude to reliable postoperative assessment. So these are the reasons why the treatment fails, because you're not able to assess it fully. There can be change in the corneal thickness, corneal edema, and which has to be adjusted. So this is one of the reasons why it's very important to be aggressive in the management of post-keratoplastic glaucomas. So the next So the difficulty in the management is the poor compliance to the drops. As much as Sharmila says is costing 350 rupees, I'd like to differ on that, because the cost of the medications, each bottle costs 350 rupees, and the total cost to the patient will be somewhere around 2,000 rupees if you put them on 3 anti-glaucoma medication. The irregular follow-up, it's very difficult. Most of them live far away. It's difficult for them to come. And the poor understanding of the nature of the disease. Once they're able to see well and the graft is clear, they don't understand they have a tiger in their bedroom. Because that is what is going to cause the problem. Because the problem is the optic nerve. You cannot afford to have the high intraocular pressure and have a clear graft and expect the patient to see continuously. So the other problem is the family cooperation, the cost to this, the person, the mental agony, the reluctance to use several drops. Already they are on steroid drops, they are on surface lubricants, and then you add one AGM, and then the second AGM, and then the third, and then now you come with the fourth Ripacidil. And so how many drops will the patient, the whole day he will be putting the drops? It has to make sense. She, I think, already told us about the high-risk cases. So these patients we have to look into. The high-risk cases, you cannot wait. You cannot wait for too long because of all the problems associated with screening. So these patients, which is already outlined, we'll have to talk about handling them much earlier and much more aggressively. So we have already, again, I think, I don't want to repeat the slide. The problem here is the corneal surface is irregular. The patient already has an ocular surface problem, and you're already going to put the patient on a lot of topical medication. Going to be very difficult to measure the intraocular pressure. And the other important thing is the formation of PAs, which can occur over a period of time. And you see a patient, ask him to come after 3 months, the pressures which were 18 would have jumped to 40 in 3 months time because the PAs is completely close the angle. So these are the problems, which are practical problems that I see every day in my cornea clinic. So she's already again dealt with the pathophysiology. The use of corticosteroids, probably the corticosteroid-induced cataract, induced glaucoma is probably the easiest to treat. But all the other glaucomas related to the collapse of the trabecular meshwork, the suturing technique, and the collapse of the anterior chamber, and the anterior chamber deformation, all these patients with pre-existing glaucomas, they are not going to respond to conventional medical treatment. So medical management, you can put as many drops, you can stand upside down, Sharmila, but you cannot manage these patients without surgical intervention. I think she already has outlined the difficulties using carbonic anhydrase inhibitors because they're going to have systemic problems. And I would like to differ again with Sharmila in that that long-term use of topical carbonic anhydrase does have an effect on endothelium. And we are talking about medical treatment, you're going to use it long term. You can use it as a short-term remedy, but you just cannot keep on using a carbonic anhydrase inhibitor topically and hope the graft to survive. So we already discussed all the topical drops cause surface toxicity. There can be conjunctival hyperemia, follicular reaction, dry eye, corneal hyposthesia, and beta-adrenergic blocker is the first line of treatment. It causes exacerbation of dry eye, superficial punctate keratopathy, and sometimes even OCP. Prostaglandin analogs, they increase uveitis, periocular pigmentation, cystoid macular edema, particularly in phakic and pseudophakic. These, you have to understand, these patients have already had a complicated surgery. Why do they develop? Most of them, they are not patients with gutta going in for surgery. They have already had a complicated surgery. They are high risk when you use prostaglandin analogs. And another important thing is patients who have viral keratitis, the chance of reactivation is more. Brimonidine, allergic conjunctival inflammation, superficial punctate keratopathy, a lot of allergic reactions again is a problem in long-term use of these drugs. Myotics, they promote breakdown of the blood-aqueous barrier and are almost given up in the management of glaucoma. There's increase in uveitis, there is stimulation of graft rejection, and increased risk of retinal detachment, particularly in a face. So the clock is ticking. Just remember, Sharmila, clock is ticking. You don't have much time. It's not like the other glaucomas. These glaucomas are intractable. So surgical management is definitely the most important thing you have to think of. And laser trabeculoplasty, and we have laser trabeculoplasty, iridoplasty, trabeculectomy, valve surgeries, and now the new kid on the block, the cyclo G6 and micropulse laser. Laser trabeculoplasty can be done in patients with open angles, clear grafts, moderately elevated intraocular pressure on glaucoma medication already. And we have already used diode laser trabeculoplasty for several years, and I think now we have to move away. And SLT seems to be a very good option, and this study highlights the effectiveness of selective laser trabeculoplasty for glaucoma after penetrating keratoplasty, and they have done several eyes which showed good response. Trabeculectomy, I would again beg to differ in saying trabeculectomy does not work. Yes, it does not work if there is, the patient has had an SICS, but it works in most other instances, and trab with mitomycin C, I think it should be the first choice of surgery if the patient is not responding to conventional SLT or cyclo G6. And the success rate has been shown in the study to be as high as 67 to 91%. I think she also quoted the same study. And they also found that this post-PK glaucoma surgery lowered the intraocular pressure effectively. And although repeated surgeries were required in some patients, did not accelerate corneal endothelial cell loss. So it's very important, if the trabeculectomy done is in good hands, then the chance of graft rejection or graft failure is very low. Again, glaucoma drainage devices, valved, non-valved, I think most of us went for AGV. The only problem is the retrograde passage of inflammatory cells and the breakdown of the blood-aqueous barrier. So these patients may need aggressive postoperative steroids. And again, the study which she quoted shows that almost 96% of the patients showed a drop in the intraocular pressure, and about almost about 30% of them needed a regraft. So probably glaucoma drainage devices should be kept as a last resort. But when you look at a one-eye patient or a patient who's had repeated grafts or is a high-risk graft, you want to save the patient's nerve. There's no point in just thinking the patient is going to go for a graft failure, so I'm not going to do a glaucoma drainage device. So it's important that you weigh the importance of glaucoma, these intractable glaucomas. The recent advances, I think Murali has spoken very beautifully about the cyclo G6. It has an effect on the uvoscleral outflow. It has an effect on the canal, the trabecular meshwork. And because of the on and off time, it reduces the thermal damage. And the postoperative pain inflammation is much less than conventional laser therapy. But however, these patients also need aggressive steroids in the first 2 weeks of postoperative period. And the results have been, though we don't really have any studies particularly pertaining to keratoplasty, we in our own hands, I do the laser along with Murali. We share the same machine. And I have done at least 3 or 4 patients who have shown excellent response to cyclo G6.
So now it's important for us to weigh which side you're going to take. Are you going to stick to your medical management and cause irreversible optical damage, or be wise and do surgical management a little bit earlier, particularly in patients who have intractable glaucomas? You don't worry about the graft failure because you have a healthy nerve, you can always replace the graft. So my choice would be a surgical management in patients who have intractable aggressive post-keratoplastic glaucomas. Thank you. And thank you once again, Chandrima.
Great talk, Sujata. Really enjoyed listening to you. Both of you were fantastic. So Dr. Chandrima, now for your take-home message.
Hello.
Yeah, we can hear you.
Yeah. Am I audible, ma'am?
Yes, yes, you are.
Yeah. Good, very good evening to all. At the outset, I would like to thank Chandrima Vaido and Kolkata Academy of Ophthalmology for giving me this wonderful opportunity. I'm truly honored and privileged to be amongst all the stalwarts of glaucoma specialty. I am only 5 years old in glaucoma practice. I'm a junior consultant at Sri Shankardeva Netralaya in Guwahati. So my take on this post-PK glaucoma. Since glaucoma is a major and a frequent complication after penetrating keratoplasty, the incidence reported is between 9 to 31% in the early post-operative period and between 18 to 35% in the late post-operative period. Even though it is multifactorial, the most common cause are because of heating viscoelastics, and majorly because of the surgery itself, including suturing techniques which contribute to the angle distortion, may cause post-operative inflammation, secondary angle closure, and pupillary block. And also because of steroid response, pre-existing glaucoma, and the surgical diagnosis itself for which the surgery was done, like post-traumatic cases, adjuvant glaucoma, perforated corneal ulcer, etc. The management is a complex issue, and it requires an insight into the pathophysiology. The initial treatment in both the early and the post-operative period is medical therapy. But when using topical anti-glaucoma medications, we have to keep in mind the side effects that are peculiar to each one of them in the setting of post-PK glaucoma. If IOP is not controlled with medications, we can do argon laser trabeculoplasty provided the graft is clear, the angles are open, and there is moderate elevation of IOP on medications. And trabeculectomy with antimetabolites is associated with increased graft survival because of fewer complications than other surgical options in cases which are not responsive to medical or laser therapy. And in cases with coexisting glaucoma and corneal disease, a better management option would be a combined filtration surgery along with PK. In cases where there is extensive conjunctival scarring, a filtration surgery is unlikely to succeed. So glaucoma drainage devices offer a better and an effective means for controlling IOP, but they also have a higher rate of graft failure in comparison to trabeculectomy. When both medical and surgical interventions fail to control the IOP, cytodestructive procedures can be performed, and it is quite successful in refractory cases. When choosing the best treatment option depends from surgeon to surgeon. Regarding all the treatment modalities, we have to weigh the risks and the benefits of the treatment measures and their effect on the survival of the graft. And the treatment of glaucoma in post-PK patients remains a clinical challenge for us as glaucoma specialists. But what we can recommend to our cornea counterparts are some preventive measures regarding the timing of the surgery and meticulous attention to surgical maneuvers that will minimize the risk of disturbing the anterior chamber angle and causing pupillary block, along with careful monitoring of the post-operative IOP, especially in response to topical steroids. The newest trend in keratoplasty nowadays is towards endothelial keratoplasty. There is limited published information regarding the development of glaucoma after DSEC, but the incidence is low. As the techniques in corneal transplantation is evolving with lower incidence of glaucoma, but as and when glaucoma does occur, it should be treated promptly. So that's my take-home message on the post-PK glaucoma. Thank you.
Thank you very much, Chinchira. That was indeed great inputs and absolutely crystal clear message across. And with that, we'll move on to the last topic of the day, and that's 25 gauge sutureless VR procedures have reduced the incidence of secondary intraocular pressure rise. And to agree with that, we have Dr. Shalini Mohan. Yeah, go ahead, Dr. Shalini.
Shalini, you need to unmute.
Yeah, thank you, Dr. Chandrima, for this wonderful opportunity. I'm talking about, I would agree with the fact that 25G vitrectomy reduces the incidence of secondary IOP rise. So in ophthalmology, we know that smaller we go, bigger we become. Like we are moving on to small incision day by day, may it be anterior segment or posterior segment surgeries. Similarly, we are also going towards being suture-less surgeries, and therefore it can be cataract, corneal surgeries or vitreoretinal surgeries. When we talk of rise in intraocular pressure after VR surgery, the various studies report incidence up to 58%. That is pretty high. Now, why and how this is happening? This is because of varied factors, may it be pupillary block glaucoma, may it be emulsified oil, angle closure, steroid-induced glaucoma, or maybe exhibition of pre-existing open-angle glaucoma. But the main thing is that it is because of endotemponad, which is happening with either BSS or silicone oil. So now, but here, this is the latest published literature on the incidence of IOP rise post-vitrectomy in our Indian Journal of Ophthalmology. And they have pointed out that incidence is pretty high, but it depends on for what indication surgery is being done. Like if it is for macular core, the incidence might be only 15%. For epiretinal membrane, it is pretty low. So it depends on the indication of vitrectomy and what are additional things which have been used. But when we are talking about the gauge of vitrectomy, the highest incidence which is occurring within a month, especially between 1 week and 1 month. So let's see that what actually leads to rise in IOP whenever we are doing vitrectomy in these patients. Now we do understand that vitreous has high antioxidants level, like with ascorbic acid and glutathione. Now as the vitreous is removed, there is increased concentration of oxygen levels, increased release of reactive oxygen species, leading to oxidative damage to trabecular meshwork, decreasing trabecular meshwork outflow facility, and subsequent increase in intraocular pressure. So basically, it is the reactive oxygen species which are leading to rise in intraocular pressure post-vitrectomy patients. And when we talk of evidence, first evidence was given by Alvarado in 1981, and this is the latest one which is published in American Journal of Ophthalmology. And they have clearly mentioned that the 8-hydroxy-D-guanosine, which is an established biomarker of oxidative DNA damage, is raised in these patients post-vitrectomy. So, moreover, post-surgical inflammation is the main cause leading to trabeculitis, pupillary membrane formation, occlusio and occlusio pupillae, leading to inflammatory cascade, release of these mediators, and again leading to rise in reactive oxygen species. So post-vitrectomy, the two major things which are leading to rise in intraocular pressure are loss of antioxidants and inflammation, and they are causing rise in reactive oxygen species. So what is the small gauge vitrectomy doing? This is decreasing ocular trauma and inflammation, subsequent to which there is decreased release of reactive oxygen species. And when we see evidence for reducing inflammation, there are numerous studies which actually explain that there is definite decrease in inflammation. Similarly, when we have smaller gauge of instrument, less infusion of balanced salt solution is required. And we know that lesser is the duration of surgery and lesser is the amount of circulating fluid, inflammation is always less. It can be true for any other surgery, may it be a cataract surgery, may it be a corneal surgery, and similar is with the BR surgery. Therefore, less of inflammation, less of reactive oxygen species, and therefore less of intraocular pressure rise in these patients. So when we look at evidence, the duration of vitrectomy is less in the patients with 25 gauge vitrectomy. Similarly, amount of DSS consumed is less in the patients of patients who have undergone 25 gauge vitrectomy. So another important thing which is happening with the sutureless vitrectomy is reduced suture-related inflammation and early wound healing. And therefore, again, inflammation is reduced, and this has been seen by histopathology also. Here we can see nice wound of 25 gauge vitrectomy. And similarly, in this UBM pictures, we can see that how well the wounds have healed after 25 gauge vitrectomy. So when there is reduced inflammation, reduced release of reactive oxygen species, and therefore less rise in intraocular pressure. In fact, when we talk of these patients of 25G vitrectomy, which are sutureless, the major concern which is found is the hypotony. And in fact, if we see, there is 3.8% to 16% of chances of hypotony in these patients who have undergone 25G vitrectomy. And literature is full of these studies which show that hypotony is pretty common, and in fact we have come up with modifications with the instrumentation and with the incision technique to reduce the incidence of hypotony. So it is not the rise in intraocular pressure in the immediate post-operative period, but it is hypotony which is of more concern. So this was the study which compared 20 gauge instrument to 25 gauge vitrectomy, and they found that there is hypotony in post-operative period of patients who have undergone 25 gauge vitrectomy in comparison to 20 gauge vitrectomy. And in fact, they concluded that there is significant lowering of intraocular pressure in the patients who have gone 25G vitrectomy. Now, this study showed that there is some rise in intraocular pressure, but then this intraocular pressure rise is pretty well controlled on medical management, and that too resolved within a 1 month's time. This is another study which was published in European Journal of Ophthalmology, and again the pressure was well controlled, and the slight rise in IOP, which was seen at first week, resolved by 1 month. So to conclude, I would say that with advent of smaller gauge of vitrectomy, we have a closed system to operate which generates less of inflammation, and hence there is less rise in intraocular pressure. And if the IOP rise is there, that too is also for a short period of time. Thank you so much for your kind attention.
Thank you, Dr. Shalini. I really enjoyed listening to that. Points put forward very nicely and very informative. So we move on to Dr. Rashmi for her to disagree with Dr. Shalini.
Can you see my slides?
Yes, yes.
Okay, I would like to thank Dr. Chandrima and KAO for giving me this wonderful opportunity. It was really nice hearing all the talks. So I will be talking on the topic that 25 gauge sutureless VR procedures have definitely not reduced the incidence of secondary IOP rise. So before going to the main topic, I would like to talk about why does glaucoma happens after pars plana vitrectomy. So after vitreoretinal surgery, there can be a transient or a sustained IOP elevation, And the incidence of glaucoma is been range from 11.6 to 20% and sometimes up to 26% also. And the incidence increases if based on whether pars plana vitrectomy is done alone or combined with other additional procedures like along with scleral buckle or with the intravitreal silicone oil or intravitreal gas or intravitreal steroids. The mechanisms also vary depending upon the various tamponading agents that are used, and also inflammation, like already Dr. Shalini has spoken about, ghostal glaucoma if it is silicone oil is used because of the silicone oil, and also the angle closure glaucoma because of the pus and the pupillary block and the gas or the silicone oil overfill. And it also varies depending upon the time of presentation. That is, if it is day one, the mechanisms are different. If it's 1 week, they're different. And if it is late onset, they're different. So basically, before talking about the main topic, I would like to tell about 2 cases that I've managed. So this is a 44-year-old male patient who came with sudden diminution of vision in the right eye 5 days, had a dermatogenous retinal detachment and underwent a right eye 23 gauge pars plana vitrectomy with endolaser and silicone oil injection. Initial 3 months, the patient's IOP was under control, but he had developed significant cataract, so cataract surgery was planned. And definitely it was a complicated cataract surgery, and because of the complication the pressure shot up, and finally we had to do a AGV for him, and after 3 years the pressures are under control onto AGM and vision of 20/60. The second patient is a one-eyed patient, high myope, surgical aphakia following cataract surgery in childhood, had an RD, had multiple procedures in the seeing eye, and 1 month later after all the retinal procedures, the IOP was 37 with the seeing vision in the seeing of 23/20. So he underwent an inferotemporal AGV because there was a buckle which was placed in the supratemporal quadrant. Though there is a high hypertensive phase and we treated that, the patient is doing well. The AGV tube we can see in the intertemporal quadrant. So among the 2 cases, what is that which is common? So what is common is the lens status. So we know that the incidence of glaucoma after vitrectomy is definitely less in cases where there are phakic, but in cases with pseudophakic and aphakic, the incidence is higher. So lens extraction is a strong risk factor. So this has been already explained by Dr. Shalini that when in an with non-vitrectomized eyes, the oxygen tension in the anterior vitreous phase and also in the posterior lens capsule is low. But once the vitrectomy is done, the oxygen tension increases, which leads to formation of cataract. Still, when the cataract is formed also, the oxygen tension in the trabecular meshwork and in the anterior chamber, the oxygen tension is lower. But once the patient undergoes the cataract surgery, the tension in the anterior chamber and the posterior chamber and also the trabecular meshwork increases, which also increases the reactive oxygen species, oxidative damage and cellular damage because of the oxygen radicals. And then whether the vitrectomy is done in a pseudophakic patient or it is done in a phakic patient who undergoes a cataract surgery later, the development of glaucoma, the mechanism is the same. And additionally, the risk factors prior to vitreoretinal surgery like diabetes, NVG, high myope, the pre-existing glaucoma and other associated conditions with lens extraction that I've already told you, the strong risk factor. So coming to the topic now, does the size really matter? So with the advent of technology, the vitrectomy probes have decreased in the size, so from 20 to 23 to 25 to 27, the cutter being closer to the tip in the 25 and the 27 gauge. So definitely the operating time is less, the inflammation is less, and then the surgeon finds it easier to operate. But does the IOP effect on IOP really has changed? So this is a randomized trial where they've done a study on 20 and 23 gauge. So basically 23 gauge, 25 gauge, they're all the lesser gauge vitrectors with suture, which are done sutureless. And then if you see the table, we can see that the day 1 IOP and day 2 IOP are only significantly lower in 23. But when it comes to 3 weeks and beyond, there is no difference between the 2 types of vitrectors. This is another study where the incidence of This is actually between 23, 25 and 27, which all of them are sutureless. The incidence is around 12.3%, which is more or less same as what it was with 20G or the earlier retractors. But if you see that in post of day 1 and up to day 21, the incidence is higher, and between the three, though it is not statistically significant, the relative risk is relatively higher with the other two compared to the 25 gauge. So this is another article which already Dr. Shalini has spoken about. If you see in this, the incidence of glaucoma has not changed at 1 day or 6 months. It is between 10 to 20%. But the peak rise of IOP that they have also noticed is the week 1 and month 1. So especially the peaks happen in the first week and within 1 month, with additional risk factors that they have noted with various pathologies that we treat, the difficult complex situations, and also the various tamponading agents. Another thing why there is less of IOP rise with newer or the sutureless retractors is the hypotony. Because there is still the healing has not happened, there is some leak that is happening, there is hypotony, or there may not be hypotony as already told. The IOP does not rise in the initial post-operative visits, that is in 1 day or 1 week, till the site closes. So there are many studies where Gupta et al. Told that post-operative hypotony was the main complication. And then this study by Kunimoto has told that endophthalmitis risk is also there 12 times because of the hypotony or the leak. And the Scott et al. Is told 28-fold risk in endophthalmitis with 25 gauge vitrectomy compared to 20 gauge. But they have come out with very modifications, like few surgeons have told that the oblique pass of the 25 gauge vitrector has definitely reduced the risk of hypotony when compared to straight entry. But the point is that the hypotony or the leak is what is causing the hypotony, or there is no IOP rise in the initial post-operative visits. But what are we worried about? The initial post-op high IOP can be definitely managed with the anti-glaucoma medication that we have. And what we are worried about is the late post-operative glaucoma that happens, that is basically because of the damage that happens because of the lack of vitreous and the increased oxygen tension that happens in the anterior vitreous space. So whatever may be the mechanism or the tamponading agents, the treatment remains the same. Initially we treat medically, and the inflammation definitely can be taken care of with the steroids that we have. And if that is not possible, then in the late phase, then trabeculectomy does not have very good results, but glaucoma drainage devices is the next that we do, or the transscleral cyclophotocoagulation. So to summarize, I am not against any technology. Definitely for the retina surgeons, the newer 23 gauge, 25 gauge, 27 gauge has made their job very easy. The transconjunctival sutureless vitrectomy, the number of surgeries have been increasing. Even the most complex cases can be performed with this type of vitrectomy, including TRD, RRD. The advantage is easy for the surgeon to use, the patient comfort, decrease operative times, decrease corneal astigmatism. But potential drawbacks are cost factor and the postoperative hypotony, and there is a possible risk of endophthalmitis. But the IOP rise that happens in the late postoperative phase definitely does not depend upon the size. So any vitreoretinal surgery is a risk factor for IOP elevation and progressive damage in the later onset. That happens because of the oxidative damage, which does not have any relation with the size of the vitrector that we use. Lens extraction definitely is a risk factor. There are various mechanisms and times of presentation, and the treatment has to be based on this. So therefore, IOP monitoring is very crucial in the follow-up of these cases. So definitely I would argue that the size of the causative agent does not depend upon the damage that happens to the eye. Thank you.
Thank you very much, Dr. Rashmi. That was indeed a wonderful presentation. And I'd request Dr. Agarwal to give his comments. Dr. Aditya.
Hi, am I audible?
Yes, you are. Yes, you are.
Thank you, Chandrima, for the wonderful opportunity, and the KAO for this wonderful meeting. I really enjoyed the whole meeting. It has been a long evening for all of us, so I'd like to be short. And Shalini and Rashmi educated me on this topic quite a lot and enjoyed both the presentations. And what I think is that the smaller the better. We have a long cataract history going from ECC to microphaco. So what I think that it is not only the size of the vitrectomy port, it is the co-procedures which are done along with vitrectomy. The oil filling, the gas, the time of the surgery, the use of steroids. So all these things do contribute to the final outcome of the surgery. So by doing a meticulous surgery with minimum surgical time, judicious use of the quantity of amount of oil, the amount of gas, and the amount of endophotocoagulation which is done. All this reduce the rise in intraocular pressure, which is may be a open angle pathophysiology or angle closure physiology. So I think giving all the procedures, minute details, and reducing the surgical time and reducing the size of vitrectomy does help in minimizing the post-op rise of intraocular pressure. So I think I'll put my cards on 25 gauge vitrectomy rather than the 20 or 23 gauge. Even 23 gauge now falls in the category of sutureless. So I think that's the take-home message, and we all had a long evening, and I thank the organizers for having me here. And it did give me an opportunity to meet all the friends on the web, and getting from Indore, which is for the 4th time the cleanest city of India. And I hope you all remember the wonderful AIOC we had 2 years back. So thank you, Chandrima, for this opportunity, and the KAO.
We all remember the wonderful AIOS and the wonderful GSI.
Thank you, Chandrima.
A great part of the organizing team, and thank you very much once again for that. Dr. Dipanjan Paul, again, you are the one who coined this. So do you want to add something before we wrap up finally?
Nothing exactly. All the presentations, we are really honored to have this platform, and this is real good debate. I'm very happy with everything. So nothing more to add. And I would also like to thank Chandrimati, Shurajit, and everybody who is behind the screen and making this possible. It's fantastic, fantastic. Everything is so good.
It was a well-planned and very well executed meetings. Enjoyed it very much. Thank you so much.
Thank you very much. So then we, if there's no one else to say anything, we move on to organizing secretary, who has very patiently put up with us the entire evening, and now it's his chance.
Unmute yourself, Rajesh.
Thank you so much, Chandrima. Ladies and gentlemen, we are having this extended virtual annual congress of Kolkata Academy for the last few weeks. It's like almost baking a fantastic scrumptious cake. And today's meeting is veritably the cherry on the top. I have no qualms in admitting that. Tagore once mentioned that, dead habits and superstitions are like dreary sands, and a clear stream of reason gets lost sometimes in that sand. Our speakers today, our panelists, are very well known, and what they've done today for us is that they have managed to drag us away from those dead habits and superstitions so that we can think in ever-widening circles of thought and action. So I thank you very much for your patience and for your guidance. I thank the veritable trio of our president, our secretary, and our governing body member, Dr. Chandrima Paul, Dr. Shurajit Chakraborty, and Dr. Shumik Chaudhary for having such a wonderful program. I thank Santis for the logistical support, and Ms. Ruchi and Mr. Rahul Jain and the team for their fantastic technical support. I thank you all again, and I hope to see you again sometime soon in Kolkata when we can host you in person. Thank you again. Bye-bye.
Thank you. Thank you, everybody. Thanks a lot.
Bye.
Thank you so much. Thank you, everyone. It was a wonderful webinar.
Nice to hear that.
Nice.
Good night.